A very good morning to one and all present here. It gives me an immense pleasure to welcome you all to the CME on Speciality Pediatrics, organized by Indian Academy of Pediatrics, Dharwad District Branch, in association with Yananga Hospital, Manipal Hospital, Yananga, and Department of Pediatrics and Neonatology, SDM Hospital, Dharwad.
On behalf of IIT Dharwad District Branch and Department of Pediatrics, SDM College of Medical Sciences, we extend a heartfelt welcome to all the dignitaries, esteemed guests, respected principal, faculty members, and postgraduates.
Today's program starts as a testimony for our institution's dedication to academic excellence, innovation, and value-based education. It's a pleasure to welcome you all to this academic session that brings together various experts from various pediatric subspecialties. Today's program features insightful talks covering advancement in pediatric neurology, immunology, endocrinology, oncology, pulmonology, intensive care, and healthcare leadership.
We are grateful to our distinguished speakers for sharing their expertise and experiences, and we look forward to an engaging and enriching session that will enhance our understanding and improve the care we provide to the children.
To begin proceedings, it is my privilege to invite our respected dignitaries to kindly come on the dais and grace the occasion.
We are deeply honored to welcome Dr. Niranjan Kumar Sir, Vice Chancellor and Chief Guest of today's function. In his absence, we'd like to continue.
We are delighted to welcome Dr. Vijay Kulkarni Sir, Principal, SDM College of Medical Sciences and Hospitals, whose constant support and infusion has greatly contributed to academic growth and institutional development. We are grateful for your presence, sir.
We extend a warm welcome to Dr. Kaval Deshpande, President, IIT Dharwad District Branch.
I now welcome Dr. Mahesh Maradihari Sir, Secretary, IIT Dharwad District Batch 2026, whose constant support and tireless efforts made us all successfully citizens.
We would now like to welcome Dr. Chetan Ginigiri, Director, Pediatrics and Pediatric Superspecialty Development, Manipal Hospital, Dharwad.
As we begin this academic meet, we would like to seek the divine blessings of Almighty. I now invite Dr. Bhagyashree, Junior Resident from Department of Pediatrics, to render the innovation song.
Jaya Ganesha, Jaya Ganesha, Jaya Ganesha, Pahi Mam. Jaya Ganesha, Jaya Ganesha, Jaya Ganesha, Raksha Mam. Jaya Ganesha, Jaya Ganesha, Jaya Ganesha, Pahi Mam. Jaya Ganesha, Jaya Ganesha, Jaya Ganesha, Raksha Mam. Mudakarat Modakam Sada Mukti Sadakam Kaladara Vasantakam Vilasi Lokarakshakam Anayakaikanayakam Vinasite Pataitakam Natashubashunayakam Namaminam Vinayakam. Jaya Ganesha, Jaya Ganesha, Jaya Ganesha, Pahi Mam. Jaya Ganesha, Jaya Ganesha, Jaya Ganesha, Raksha Mam. Jaya Ganesha, Jaya Ganesha, Jaya Ganesha, Pahi Mam. Jaya Ganesha, Jaya Ganesha, Jaya Ganesha, Raksha Mam. Jaya Ganesha, Raksha Mam. Jaya Ganesha, Raksha Mam.
Thank you, ma'am. That was a beautiful rendering. The lighting of the lamp is a time-honored tradition, symbolizing the triumph of knowledge over ignorance and spread of wisdom and enlightenment. May I now request all the esteemed dignitaries on the dais to kindly light the lamp and inaugurate the program.
shall move forward to welcome today's guest. It's my privilege to invite Dr. Kamal Deshpande, President, IAP Dharwad District Branch, to address the gathering and extend a warm welcome to all the dignitaries.
Good morning, everyone. Respected dignitaries on the dais. Today's chief guest, the principal of STM Medical College Hospital, Dr. Vijay Kulkarni sir. The Director of Pediatric Super Speciality Services from Manipal Hospital, Yelahanka, Bangalore, Dr. Chetan Gidigiri. The Secretary for IIP Dharwad District Branch, Dr. Mahesh Mandiyari. And the entire distinguished team from Manipal Hospitals, Yelahanka, consisting of Dr. Shanti M, Dr. Sagar Bhatter, Dr. Shyam Kiran, Dr. Aarti, Dr. Shrikantha, and Dr. Harish Kumar. I also extend a warm welcome to all the respected pediatricians of Hubli Dharwad, all the undergraduates, the postgraduate students from STM Medical College, Karnataka Medical College, and our esteemed invited guests. On behalf of the Indian Academy of Pediatrics, Dharwad District Branch, it gives me immense pleasure to welcome you all to this CME on the super specialty of pediatrics. This is done in association with Manipal Hospitals, Yelahanka, and in association with the Department of Pediatrics and Neonatology, STM Medical College and Medical Sciences and Hospital, Dharwad. So today's gathering reflects a shared commitment towards a common purpose, that is to learn, to update ourselves and to enhance the quality of care that we provide to our patients and the children. So pediatrics is a very dynamic field, as you all know, where knowledge is constantly evolving, and what we learn today directly influences the decisions we make tomorrow in our clinics, in the wards, and in the intensive care units. So we are privileged to have with us the eminent team of pediatric super specialists from Manipal Hospital, Yelahanka, Bangalore, led by Dr. Chetan Gidigiri. And each member of this team brings with them immense clinical experience, academic excellence, and exposure to complex pediatric problems. The topics chosen for today's CME are not random. They are handpicked carefully, and the subjects are based on the real-world clinical relevance. Areas where practical insights from super specialty practice can significantly benefit the general pediatricians and the postgraduate trainees as such. There is a beautiful saying which goes like this: the eyes cannot see what the mind does not know. This simple statement highlights a profound truth in medicine. Our ability to recognize, diagnose, and to manage diseases is deeply influenced by the knowledge, experience, and the perspectives we carry in our minds. So the more we learn, the more we begin to notice subtle clinical signs, earlier diagnosis, and the better management strategies. So therefore, programs like today's CME are not merely an academic gatherings. They are an opportunity to broaden our perspectives, refine our clinical thinking, and bridge the gap between the super specialty care and day-to-day pediatric practice. When experts share their experiences, they not only teach us the guidelines but also the nuances, the clinical pearls, and the decision-making process that come only with years of dedicated practice. So I'm confident that the sessions planned today will be very engaging, very practical, and intellectually stimulating. And I encourage all the participants, the postgraduates and undergraduates, to come up, ask questions to the esteemed faculties, clear your doubts on the topics that are being discussed today, and make the most of this wonderful learning opportunity. So saying this, I once again thank the whole team of STM, Medical Sciences and Hospital, and thanks in special to Dr. Vijay Kulkarni sir. He's been a mentor, he's been a guide, he's been a support. All these medical initiatives that the IIT Dharwad Grant has been organizing this year. So thank you very much sir, for your kind support and your guidance. So I wish everyone a productive and an enriching learning academic day today. So thank you and a happy learning.
Thank you, sir. I would now request our respected principal, sir, Dr. Vijay Kulkarni, to address the gathering.
Good morning, one and all. Om Shri Manjunathaya Namaha. It's a great honor and privilege for me to welcome the esteemed faculty from Medical Hospital, Yelahanka. Today is a unique day not only for all of us, but mainly for the postgraduates and undergraduates. How we have started our journey 25 years ago when we did our pediatrics. 25 years exactly now, when I was doing a postgraduate. Now it is totally different. Pediatrics has many subspecialties now. You can call them a super specialty, but I would rather call them a subspecialty. And it has evolved so much. Our understanding of the subject has become so much. And by the time you people come and practice, our undergraduates, our postgraduates come and practice. So you will have an idea how the medicine is evolving today. Today we are going to have an overview of pediatric subspecialty series. And we are very lucky to have an eminent faculty all together. We have Dr. Chetan here, who is heading the pediatric division of Medical Hospital, who is the director. Warmly welcome to you, Chetan, for our hospital. And we have an eminent fellow, Dr. Sagar. Just to tell you, you should get inspired by him. He is the first DM pediatric immunology candidate from PGI. In 2016, PGI started the DM program separately in pediatric immunology. Okay, so after his MD, he pursued his DM immunology, and he's been practicing in pediatric immunology, and he's been a great help and support to us. Lot of rarer things which have become very common thanks to him for all the modules and our sensitization of primary immunodeficiency disorders. And I have a lot of youngsters who have come. Please forgive me, I may not remember your names. There's a hemato-oncologist there, there's a pediatric endocrinologist, there's a pediatric pulmonologist, and there's a pediatric emergency guy there. So all 4-5 branches of pediatrics, subspecialty of pediatrics are all there. The reason why we involved the undergraduate, don't curse me today. Annapurna mess alli ಆರಾಮಾಗಿ ಹೇಳೋದು breakfast ಮಾಡೋದು, I know it is. Sunday I know you would love your breakfast of dosa. I believe today there is dosa in the mess. Okay, our PGs make use of our beautiful mess what we have. You kindly stop ordering Zomato and Swiggy because you are paying for the mess bill in Annapurna. Please go and have your food in the mess only. ಆಯ್ತಾ? ಆಮೇಲೆ ನಿಮ್ಮ ಪೇರೆಂಟ್ಸ್ ನಮಗೆ ಫೋನ್ ಮಾಡ್ತಾರೆ, ನಮ್ಮ ಮಕ್ಕಳಿಗೆ ಅಷ್ಟು ನೀವು ಟೈಮೇ ಕೊಡೋದಿಲ್ಲ, ಅಷ್ಟು ಬ್ಯುಸಿ ಆಗಿದ್ದಾರೆ ನಮ್ಮ ಮಕ್ಕಳು. ಸಡನ್ಲಿ ಯು ಸ್ಟಾಪ್ ಕಾಲಿಂಗ್ ಯುವರ್ ಪೇರೆಂಟ್ಸ್ ಒನ್ಸ್ ಯು ಜಾಯಿನ್ PG in STM. Don't do that. You always have time to call your parents and tell. Please suddenly don't do that. because they come and complain to our principal office that ಏನ್ರಿ ನಮ್ಮ ಮಕ್ಕಳಿಗೆ ಮಾತಾಡೋದೇ ಇಲ್ಲ, ಏನಾದರೂ ಪ್ರಾಬ್ಲಮ್ ಇದೆ ಅಂತ ಕೇಳ್ತಾರೆ. You should convince and tell them that you have come here to learn, not to talk. Once in a while you can call them, morning aramidya. I think that should be enough. Okay, and because yesterday itself 2 parents of OBC department came and told me that you people are giving no time for her to have lunch. I felt you should be happy for that. She is not having time because many of the colleges don't have patients. And you are happy that you are having so much of workload, and on the contrary you are coming and telling me that. And they wanted our mess timing to be open till 11:30. How it can be possible? They are also human beings. Till 10:30 they have to close, they have to clean the mess and all. But still we are planning to give you some food packets to the labor room. That's a different issue. But I think you have to manage your time. Manage your time and breakfast. Don't suddenly have loss of weight. Okay, some 7 or 8 kgs. They were complaining that the PGs are losing weight. I felt it is really good, unless it is not pathological. Okay. So with these few words, once again, I wish all the undergraduates and postgraduates, and once again I thank the IAP office bearers for choosing STM as a venue. Actually, our Vice Chancellor would have loved to meet all of you. Because of his personal commitments, he could not attend the program. On behalf of STM University, on behalf of the Vice Chancellor and and the family of Hegde sir, we warmly welcome each one of you to our campus. Thank you. Have a pleasant day.
Thank you so much, sir. Now, may I like to invite Dr. Chetan Gingeri, sir, to kindly address the gathering.
Good morning, everyone. Heartfelt thank you to the SDM Dharwad University, Kulkarni sir, and IAP Dharwad, Mandesh, and Dr. Kavan. So, we are here basically on their invitation to share some of our knowledge and experiences with all of you. As Kulkarni sir told, the specialty of pediatrics is evolving, and pediatrics is no longer general pediatrics, office pediatrics. It has evolved from neonatology to all the acute specialties of emergency, ICU. And you will also hear from a lot more specialists. Some of them are organ-specific specialists like pediatric neurology, pulmonology, endocrine. Some of them are very generic specialties like pediatric hemato-oncology and immunology. The whole specialty of pediatrics is evolving, and newer specialties with genetics and other interventions that are now making us able to diagnose rarer diseases. And as even the economic, social, cultural structures of families and the whole style of child rearing is changing, children's mental health is also a significant issue that we are going to face. So the landscape of pediatric diseases are going to shift from infectious diseases to maybe trauma, lifestyle diseases of children, and genetic metabolic diseases, which are going to occupy your patient load for the future. So we are moving in that direction, and I think in this transition, the faculty who are here will be able to give you a sneak peek into what's awaiting for your future and the specialties that you should choose for your career progression. So with that, thank you, sir. Thank you so much for the invitation, and I hope you do justice to the invitation. Thank you.
Thank you, sir. I would now like to invite all the speakers onto the stage for a group photo.
Sir, ready?
Hello.
Sir, wait. Okay, sir.
Thank you, everyone. With that, we shall now move on to the scientific session. We have an excellent lineup of experts to speak and on various topics. We would now like to invite Dr. Shanti M. to deliver a talk on autoimmune encephalitis, latest updates. Dr. Shanti ma'am is a consultant in pediatric neurology at Manipal Hospital, Yelahanka, Bangalore. She holds an MBBS and MD in pediatrics and has completed IAP fellowship in pediatric neurology.
She holds 8 years of experience in pediatrics and 3 years of dedicated experience in pediatric neurology. Her areas of expertise include pediatric epilepsy, drug-resistant epilepsy, developmental delays, cerebral palsy, neurometabolic and neurogenetic disorders, neuromuscular disorders, autism and other neurodevelopmental conditions. With her extensive clinical experience and special interest in pediatric neurological disorders, she brings valuable insights into evolving field of autoimmune encephalitis. On to you, ma'am.
Good morning, everyone. Thanks for those kind words. My topic for today is autoimmune encephalitis. The reason behind choosing this topic, as already discussed, the infectious diseases are somewhere reducing in number, and there are a lot of other disorders which have become more and more common these days. One of the important topics in that lineup is autoimmune encephalitis. So, outline of the presentation. We'll see a few case scenarios, then go to the definition, pathogenesis, clinical features, investigation, treatments. And towards the end, we'll see a few newer concepts that have come up in the field of autoimmune neurological disorders themselves. So first case scenario, this is an 8-year-old male child who presented with history of multiple episodes of focal and generalized tonic-clonic seizures, behavioral issues, irrelevant talking, visual hallucinations, and sleep disturbances. He had a history of viral fever 2 weeks before this presentation, treated on OPD basis. Otherwise, no significant past or family history. He was a developmentally normal child before the onset of the illness. At admission, child was an altered sensorium, no cranial nerve involvement or focal motor deficits were noted, no meningeal signs were present. So on investigating him, CSF analysis showed 5 cells, all were lymphocytes, protein and sugar were normal, MRI brain normal, EEG showed some multifocal interictal epileptiform discharges. Any guesses on the diagnosis? The topic has the answer. Yeah. So this was a case of autoimmune encephalitis, but when we did the CSF autoimmune panel, it was negative. This is another case. A 9-year-old male child with history of cognitive decline, aggressive behavior, temper tantrums, echolalia, poor eye contact, and which was progressive for the past 1 year. So this was quite a long-standing history. With no other significant history. On examination, he only had poor eye contact, poor interaction, echolalia, and a lot of aggressive behavior towards the parents. Otherwise, no other deficits, no movement disorders. This child was being treated as autism elsewhere. When we investigated him, CSF showed 4 cells, 100% lymphocytes,
A normal
protein and sugar.
MRI brain showed left medial temporal lobe hyperintensities on T2 and flare. EEG was normal. Any guesses about the diagnosis here? Again, the topic, autoimmune encephalitis. This history, though not very typical, the panel picked up anti-NMDAR receptor antibodies. So why is this topic important? Because this is a very, very confusing subject, where it is clinically very, very typical, antibodies come negative, every other investigation is normal. And then on what basis do we treat it? And when clinically it is not fitting all the criteria, antibodies come positive. So treating this disorder is a very, very confusing aspect, and that is why there are a lot of recent updates that have come on this subject. There are consensus guidelines which have come up, which help us to identify these children earlier in the course of the disease and treat them appropriately. So coming to the definition, encephalitis is any inflammation of the brain parenchyma which is associated with neurological dysfunction. When we talk about autoimmune encephalitis, this is a group of non-infectious, immune-mediated inflammatory disorders of the brain parenchyma, often involving the cortical and the deep gray matter, with or without the involvement of the white matter, meninges, or the spinal cord. So what usually happens? They present with acute or subacute onset of neuropsychiatric symptoms due to an underlying abnormal immune process. The abnormal immune response can be anything. It can be loss of immune tolerance, it can be abnormal activation of the acquired immune system, T cell, B cell mediated, or both together. So usually they respond to immunosuppressive therapies, and mostly in adults they are associated with neoplastic conditions, not very common in pediatric age group. So what is the pathogenesis? We know of 2 things that can cause autoimmune encephalitis most of the time. One is an infective trigger, one is a systemic tumor. So what happens when there is an infective trigger? There are damaged neurons, because of which there is antigen exposure. On the contrary, in a systemic tumor, the apoptotic tumor cells, the cells basically eat the tumor cells and release a lot of antigens into the system. The dendritic cells take this up, go into the regional lymph nodes. Over there, they present it to the naive B cells with the help of the CD4 cells, from where the cells differentiate into plasma cells and memory B cells. These memory B cells are the most important ones because they cross the blood-brain barrier, enter the brain, and there they start producing antibodies. So this is the intrathecal synthesis of antibodies that we talk about most commonly in your autoimmune encephalitis. Whereas these plasma cells produce antibodies in the systemic circulation, so sometimes even the serum antibodies are positive. So both the ways they're producing antibodies. These antibodies act in various ways depending on the antibody that we identify. When we talk of GABA receptor antibodies, they basically block the target antigen itself, causing symptoms. When we talk about NMDA, they basically cause internalization, cross-linking and internalization of the receptor itself. That is why there are symptoms that come up. And various other antibodies act on different phenomena. So now that we are talking about autoantibodies, what are the common antigen targets that we are looking at? They can be either extracellular or surface antigens, or there can be intracellular antigens. The common extracellular or surface antigens that we talk of are NMDAR receptor antigens, VGKC receptor antigens, which can be LGI1 or Caspar2, GABA A receptors, GABA B receptors, glycine receptors, glutamate receptors, etc. And when we talk of intracellular antigens, these are GAD, HU, MA, and YO. Commonly in pediatrics, in adults there are many more antibodies which are seen, basically because of the oncological presentation along with them. So why identifying these antibodies are important? Extracellular antibodies usually are against cell surface proteins, ion channels, or receptors. So they disrupt the functioning of the target antigen, because of which they cause symptoms. And the symptoms, and these antibodies are usually pathogenic. So when we identify these antibodies, we know these are the ones that are causing trouble, they are the ones that are pathogenic. They cause reversible neuronal injury because it is B-cell antibody mediated. There's a very good response to immunomodulation. Symptom is reversible with treatment, early treatment especially. Much less consistently associated with neoplasms, and there is a relatively very good recovery, and this is the most common subtype that we see in the pediatric age group. When we talk about intracellular antibodies, these are mostly intranuclear more than cytoplasmic. They are inaccessible antigens, so the antibodies are basically not pathogenic. They are not the ones who are causing the trouble. So this is part of a T-cell response to the tumor that is present. There is extensive tissue damage that occurs. There's a very poor response to immunotherapy, commonly associated with tumors, as already told, and there is a very poor recovery when it comes to intracellular antibodies. What are the common clinical features with which children present? It can either be neurological or it can be psychiatric. So when we talk about neurological features, there will be altered level of consciousness. Seizures is the most common finding. Almost 80% of children will have seizures when they have autoimmune encephalitis. It can be focal, generalized, multifocal, anything. There will be confusion, there will be disturbed sleep. Movement disorders can be commonly seen. Cognitive impairment is a very cardinal feature of autoimmune encephalitis. Speech and language impairment and dysautonomia can be seen. On the contrary, there are a lot of psychiatric features with which children can come. There can be repetitive stereotypical behaviors, irritability can be seen, hyperactivity, insomnia, anger outbursts, even to the extent of fulminant psychosis. So all of this can be seen in autoimmune encephalitis. When we talk about the features and cause, this is very specific for NMDA receptor antibody in related encephalitis. Usually there's a prodromal phase. There is a fever, headache, nausea, vomiting, upper respiratory tract kind of a symptom, which happens generally 14 days prior to the symptom onset. So we roughly tell that 2-week period for any kind of autoimmune disorder. Then there is an illness phase. In that, there is a psychiatric phase and a neurological phase. Initial 1 to 2 weeks is the psychiatric phase where all the psychiatric symptoms set in. And then the neurological phase comes, which can go on for weeks to months if we do not treat the child. When we treat them, we see the other two phases setting in. That's the recovery phase and the late phase. Recovery usually happens in the reverse order of symptom presentation, and cognitive function and psychiatric issues are the slowest to improve. So they take maximum time to improve. And the late phase, if treated early, there is a full recovery of cognition, behavioral abnormalities. This is the most important point. That is why identifying them early and treating them early helps them to get back to their normal function. And the various antibodies that we spoke of, we will skip the entire thing. We'll talk only about two things, the commoner ones. One is NMDAR. This is usually seen in young children, mostly females, acute onset. There will be mixed both neurological and psychiatric symptoms. Complex movement disorders will be seen, and they'll have dysautonomia, and it is usually associated with ovarian teratoma, more so in adolescents and adults. Pediatric age group, still less. The second most common thing is MOG. MOG antibodies can also present with autoimmune encephalitis. These are again seen in young patients. It presents like ADAM. So there is a fulminant presentation. With that, they can also have optic neuritis or transverse myelitis. So what are the common investigations that we're going to be doing? First thing, CSF analysis. So what do we see? We see CSF pleocytosis, 20 to 200 cells usually, sometimes even more than that. Mildly elevated protein is something that we see. Along with that, oligoclonal bands being positive shows intrathecal synthesis of the antibodies. So it is one of the important tests that we do. CSF plus or minus serum antibodies we do, and by cell-based assay, they give us the best reports. CSF is almost 100% sensitive, so the moment we see a CSF autoantibody positive, it almost confirms a diagnosis. On the contrary, serum up to 85% sensitive, depending on what antibody we are thinking of. Next investigation, MRI brain. Depending on what antibody it is, MRI pictures also tend to change. So NMDAR most of the time has a normal MRI brain. So that is where the picture again gets confused. Sometimes they can have some non-specific T2 flare hyperintensities, but most of the times the MRI is normal. If changes are there, it is again in the medial temporal lobe or in the hippocampus. The second picture is of DOPA receptor, where the basal ganglia is typically involved. The third picture is limbic encephalitis, where your typical limbic areas are involved, the medial temporal lobe and the hippocampus are involved. This is a picture of GABA receptor, where there is like diffuse involvement, cortical, subcortical, everything is involved. This is SMOG antibody related, where it presents like ADEM. There is like diffuse, fluffy hyperintensities all over the brain, basal ganglia everywhere. So this is just a picture which tells you which part is involved in which antibody related thing. So most of them are adult related. The limbic encephalitis is mostly seen in the adult oncology related autoimmune encephalitis. NMDA can come with frontal, medial temporal everywhere. Brainstem is anti-MA usually. Anti-GABA is multifocal as shown in this picture, and deep gray matter is seen in anti-CV and also in dopamine receptor antibodies. The next investigation that we commonly tend to do is EEG. There are a few patterns that are very specific for autoimmune encephalitis. One of the most important one is this. This is called as extreme delta brush. So what are we talking about? We're talking about slow waves that are delta waves. On top of these slow waves, we tend to see a lot of fast activity. That is the beta activity. So this is one of the findings in the EEG, which is very typical for NMDA receptor antibody related encephalitis again. So recently in 2020, there was a diagnostic criteria that was put out for the pediatric autoimmune encephalitis. The reason behind it, as we saw in the initial two case scenarios, clinical symptoms very typical but no antibodies, or clinical symptoms are not very typical of autoimmune encephalitis but antibody is positive. So what do we do in such scenario? We classify things into three types. There is a possible autoimmune encephalitis, there is a probable antibody negative autoimmune encephalitis, and there is a definitive antibody positive autoimmune encephalitis. So based on symptoms, we are seeing what symptoms are there. There can be altered mental status or level of consciousness or EEG abnormality, focal neurological deficits, cognitive difficulties, acute developmental regression, movement disorder, psychiatric symptoms, or seizures which are not explained by other causes. When two or more of this is present, it has to be there in all the three subcategories that we are looking at. Along with that, what differentiates these from the other two is the paraclinical evidence. Either a CSF showing some pleocytosis or oligoclonal bands, a MRI feature of encephalitis, or a brain biopsy showing inflammatory changes. If we have at least one of these, we can put it as probable antibody negative, or if the antibody is positive in the later section. But if we do not have these, then it becomes possible autoimmune encephalitis. And then we do a autoimmune encephalitis serology, presence in serum or CSF, then it becomes definitive diagnosis. If it is not there, but MRI and clinical features are still fitting, we can call them as probable antibody negative autoimmune encephalitis. The first case that we saw, clinical picture fitting, everything else negative, we can diagnose it as a possible autoimmune encephalitis and still treat this child. So coming to the treatment. These are the various medications that we can use in autoimmune encephalitis. The common first line ones being IV steroids, oral steroids, plasma exchange, and IV immunoglobulin. The second line being IV rituximab and cyclophosphamide, and the extended second line or the third line is tocilizumab these days. So how do we know which patient to start where and how to go about it? So that is where this guidelines in 2022, this was a consensus guideline on NMDAR receptor specifically. So they came up with severity classification. So we either diagnose them as standard or severe autoimmune encephalitis. Based on this, we decide what treatment we're going to start with in these children. So standard is they do not have any airway compromise, they don't need an ICU care, they are not bed bound, they don't need 24/7 nursing care, their psychiatric symptoms are not that severe where they're going to end up self-harming or harming others. They are able to take self-care, communication is still sort of maintained, they're sort of alert, seizures is not too much that controlling seizures is difficult. So this is what is the standard category that we're talking about. On the contrary, we have a severe category as well. So depending on what it is, if it is a standard disease, we can start with first-line immunotherapy, either IV methylprednisolone with an oral taper, or an add-on of IVIG, most of the times we do give. So after that, we see for improvement. If they improve, we put them on prolonged first-line immunotherapy, which can either be a monthly IV steroid, or a taper of oral corticosteroids, or a monthly IVIG. Any of these can be given. And if the patient responds in this line, they are the best responders. They usually require only 3 to 6 months of treatment, and they tend to recover well to their baseline. But if this is not happening, or there is a severe disease at onset, we tend to go ahead with 2 first-line therapies at once. It's either IV methylprednisolone with IVIG. If the child is very sick, we tend to do Plex and then give them IVIG. At the same time, we've also started corticosteroids. So based on the improvement, we classify them. In the next 2 weeks, we see if they're improving. If they're improving, we call them as average responders. We'll still continue giving them oral taper of corticosteroids or monthly IV steroids or IVIG. But they're called as average responders because they require slightly longer period of treatment, and their recovery is also takes a slightly longer time duration. The third category is this, where you gave 2 first-line treatment, but 2 or even 3 first-line therapies, the child still didn't improve. That is where we give rituximab, the second-line immunotherapy that we are using these days very commonly. So once we give all of these, if they respond, well and good. If they don't respond, we have to escalate to tocilizumab. That is the next line therapy, which is the extended second-line immunotherapy or the third-line immunotherapy. And these are called as poorest responders. Their return to baseline can be a little difficult, and these patients are the ones who mostly have an oncological condition associated. So treatment of the underlying cancer, removal of the cancer itself sometimes helps in recovery in these children. So differential diagnosis, huge list. Anything and everything can be a differential diagnosis to autoimmune encephalitis, because it sort of becomes a diagnosis of exclusion if we do not have an antibody positive. So anything that can come with altered sensorium can be a differential diagnosis for autoimmune encephalitis. What are the common associated tumors that we are looking at? For us, this is the most important one. Ovarian teratomas, rarely testicular germ cell tumors, and small cell lung carcinomas can be seen. The other ones that come in the pediatric age group are usually associated with thymomas, and most of them are like the adult counterparts, where there is small cell lung carcinoma and other things. So what do we commonly screen for? Basic things we have to do is a chest X-ray, ultrasound abdomen and pelvis in a female, ultrasound abdomen and scrotum in a male child. These are the basic things we do. In case there's a doubt, PET scan is the best thing to diagnose any kind of underlying oncological conditions in these children. So the newer concept in autoimmune encephalitis is autoimmune epilepsy. So what is this? When a child has autoimmune encephalitis, if the child is having seizures, that is called as an acute symptomatic epilepsy secondary to autoimmune encephalitis. This child gets treated, goes home, but continues to have seizures. So this is what is called as autoimmune associated epilepsy or post-autoimmune epilepsy. But now there's a third thing that we're talking about. This is called as autoimmune epilepsy or immune-mediated seizures, epilepsy without encephalopathy. So what is this? These are a cluster of seizures that occur over a few days to few weeks that are resistant to multiple anti-seizure medications in a premorbidly normal child. And there is no encephalopathy in this condition. This is what differentiates autoimmune encephalitis from this condition, because there's no encephalopathy. Children are coming only with a cluster of seizures to us. It's again a diagnosis of exclusion. Like autoimmune encephalitis, we have to have a negative investigative workup for all the common causes, including a 3 Tesla MRI with epilepsy protocol, EEG being non-specific or normal, all the blood work should be negative, and LP should be normal. They should fulfill the diagnosis for drug-resistant epilepsy, that is at least 2 drugs in full proper dosage. The good thing is they respond to immunotherapy, and early treatment is usually associated with good long-term outcomes. That is what suggests an immune pathogenesis in this condition. And there was the first paper on this topic came out from Karnataka, from KLE Belgaum. They are the ones who have been working on this extensively. We have seen a few kids who actually respond very well to IV steroids, and the seizure control is pretty good. So the proposed pathophysiology underlying this condition, it can be a more localized presentation of an autoantibody associated or a localized T-cell innate immunity mediated injury affecting neurons, mainly in the motor cortex. Infection is the commonest trigger, like any other autoimmune condition. And it can be anything, again, same thing, molecular mimicry, neuronal, immunity-mediated neuronal injury, bystander activation, B-cell receptor-mediated co-capture of antigens, etc. So a field which is still under research. Hopefully we'll have more answers on this as well in the near future. These are my references, and thank you. Any questions?
So if you have any questions to be asked, please you can raise your hands.
Hello ma'am, there were 2 cases you told initially. One was 1 year presentation and one was 2 weeks presentation. For 1 year presentation, how did you come to the conclusion that it is autoimmune encephalitis? Why not white matter NDD?
We did all the investigations. So basically, it was a neuroregressive disorder. So we started off in the terms of neuroregressive disorder. We got an MRI. MRI was very typically suggestive of autoimmune encephalitis. We did a CSF. We also did genetics in this child. Though we got the serum antibody positive, because it was serum and not CSF, we were still doubtful. We got genetics also done. Everything was negative, and he started responding to immunotherapy. So we, like, as a diagnosis of exclusion, labeled him as autoimmune encephalitis.
There was no underlying any oncology?
No, sir. We did a PET scan on him, normal.
Madam, when these younger children present, the acute viral encephalitis and these will overlap. So how early we should start intervention if fetal autoencephalitis is our diagnosis and we don't have support from either MRI or CSF analysis studies?
It is a very tricky thing, sir. If we do not do MRI and CSF, deciding on giving steroids is a very double-edged thing. If we are treating an infective condition, then it can be a difficult, tricky thing. The ideal timeline would be 48 hours to 72 hours. After starting a treatment for infection, we generally expect some response to set in that time. If we're treating with antibiotics, supportive care, viral encephalitis also sort of starts to improve in that meantime. If there is clinical worsening, behavioral issues set in, the child's sensorium drops, with the major things that can point is movement disorders, sleep disturbances. If we see all of these, we can empirically start thinking of autoimmune encephalitis and start them on steroids.
Because autoencephalitis workup will take some time.
Yes, sir. Most of the cases, what we do is we do an MRI LP and we start off. Because the antibody report itself takes 48 to 72 hours for us to come. We send it to NIMHANS basically. So we don't wait in that time period. Once clinically it is sort of clear, we start off treating and then wait for the results to come by.
How late can these be given? Steroids and
late, better late than never is the answer. So whenever they come, it's better to start.
If it is in the second week of illness,
this child came at 1 year, sir. We gave him. So whatever timeline they come, immunotherapy helps. At least for some amount of recovery, it helps. The only problem with treating them late is the recovery is not complete. As in the second case, the child still has a lot of issues going on. He's not completely fine. We have given him 2 doses of rituximab as well. But child did not respond as well as an acute case.
I just wanted to know how safe is it to give the monoclonal antibodies in a pediatric setup without having all those extended subspecialty branches at your place?
That might be a little difficult because we always have Sagas's help before we give all of those antibodies.
If as a pediatrician in the periphery or in standalone pediatric hospital, so how safe is it to use those antibodies?
Rituximab generally doesn't have a very bad side effect profile, sir. It's generally safe to give. Compared to the set of monoclonal antibodies that we are using, rituximab is probably the safest one. So we are giving them, but before them there's a workup that we have to do, commonly rule out all these hepatitis and those conditions because there can be a flare-up once we give rituximab. So we rule them out, we send CD counts, and then we start on rituximab. I think Saga sir.
Exactly, because as a clinical pediatrician, you go through the algorithm and then you see that you have this to be given. So just giving that as an option, it's not an option. So you'll have to have a previous workup for that.
No, sir, I agree with your question and the challenges. There are 2 answers to it. One is deciding on rituximab itself is a difficult question, and many times obviously the primary pediatric neurologist decides that yes, this is autoimmune encephalitis, we have given steroids and there is incomplete response or there is relapse. So that is point number 1. Are you sure you want to give rituximab? And once you have decided, then there is a clear workup. I don't think that is very difficult because certain viral infections, especially hepatitis B, is an absolute contraindication for giving rituximab. So you rule them out. I would always suggest do a baseline immunoglobulins and a B cell count because we have had situations where then patients become hypogammaglobulinemia post rituximab and you're not sure whether they were already having a gammaglobulinemia to begin with. And then I don't think giving rituximab itself is a big challenge because you have to deal with anaphylaxis, which is not very common, which is rare. But then there are long-term side effects that one needs to monitor. Now, once you give rituximab, there is a small chance that these patients can develop hypogammaglobulinemia. So have you done the right counseling before giving the medication is the last question.
We look at is the safety of the pediatricians, the MLC aspect, the medical legal. So that is what we need to take care of.
Yeah. I think without obviously a pediatric neurologist saying rituximab is required, I would hesitate to give rituximab.
So if there are no more questions, then we'll proceed to the next topic.
Thank you, everyone.
Thank you very much for an insightful talk, ma'am. Moving on to our next talk, that is on immunodeficiencies, care and cure from zebra to chimera. We are privileged to have with us Dr. Sagar Bhattar, an eminent expert in the field of pediatric clinical immunology and rheumatology. Dr. Bhattar holds an MD and DM pediatric clinical immunology and rheumatology and has also completed a fellowship in bone marrow transplantation. He is certified by the European Society for Blood and Marrow Transplantation with the prestigious EBMT diploma. He currently serves as a lead consultant in pediatric immunology, rheumatology, and bone marrow transplantation at Manipal Hospital, Yelahanka, Bangalore. Notably, he is the first DM specialist in pediatric immunology and rheumatology in India. Dr. Bhattar has an impressive academic record with over 80 publications in peer-reviewed journals and is the author of the book Primary Immune Deficiencies Made Simple. His research contributions have been recognized with Major General Amir Chand Gold Medal for Research in Pediatric Lupus. Clinically, he has diagnosed more than 550 patients with primary immune deficiencies and has been involved in around 58 bone marrow transplants for these conditions. With his vast clinical expertise and academic contributions, we are certain that today's talk will provide valuable insights into the evolving landscape of diagnosis and curative therapies of immune deficiencies. I now invite Dr. Sagar Bhattar to deliver his talk on immune deficiencies, care and cure from zebra to chimera.
So, good morning one and all. At the outset, let me thank once again Kavan sir, Mahesh sir and the entire IAP Dharwad, Hubli Dharwad I must say, for giving us this opportunity. I think some of you know, most of you don't know that for the last 3 months we have as a team moved to Manipal Hospital Yelahanka, and it was a very a pleasure and a coincidence when Dr. Kavan called me and said, can we have an academic session? I have taken over as the president of the IAP here. And I said, this is absolutely welcome, because I was about to call you and it's the only coincidence that you called me. And once again, thank you sir, and thank you everyone for having us this Sunday morning. The topic that I have chosen to speak upon is immune deficiencies, care and cure from zebra to chimera. I'm sure some of you would be wondering what is this zebra, but I'm sure everyone would be wondering what is this chimera. Hopefully I'll try to answer both those questions through my talk. I bring greetings from Manipal Hospitals. There are two objectives of my brief presentation today. The objective number 1 is to think of zebra, right? And the objective number 2 is to convert zebra into chimera for the well-being of the child. Let's see what it means. I'm sure you know what is a zebra, and some of you might know what is a chimera, right? So chimera is actually a hypothetical mythological animal which has got multiple animals within: the head of a lion, the body of a goat, and the tail of a serpent, right? Let's go to the objective number 1. Immune deficiencies as a group of disorders, when they are genetic in origin, we call them primary immune deficiencies. And naturally, you must rule out secondary immune deficiencies before proceeding to workup. For example, HIV must be excluded before you think of a primary immune deficiency. We all know a healthy immune system fights infections, but please remember, a healthy immune system also kills cancer cells and has self-tolerance. That means it does not attack self. So that means when you have an immune defect, you would not only be predisposed to infections, which is easy to understand, but you will also be predisposed to cancers and autoimmunity. That's a wonderful paradox. On one side, I say these patients can develop infections. On the other side, I say they can develop autoimmunity. The first presenter just spoke about autoimmune encephalitis, and we have cases of immune deficiencies that have presented to us with autoimmune encephalitis. And that is because they can have autoimmunity. So the world body, which is the Immune Deficiency Society, thought it is better to rename these conditions as the inborn errors of immunity, highlighting the diverse spectrum with which these patients present to us. For you to remember, that's a simple picture. I'm sure every one of you has watched this movie, right? So just don't remember low immunity. On the other end of the spectrum, there is autoimmunity. This is the latest update that was published, I would say a couple of years back. They publish it every 2 years. And what did they say? How many numbers of inborn errors of immunity? 559 diseases. So as I speak, this is not a single disease. And 67 new gene defects were identified only in the past 2 years. So every year, new diseases are being identified thanks to the advancement in molecular science. How common are these diseases? They are not rare. 1 in 1200 people are said to be affected with a primary immune deficiency. And as I speak, we sit in India with a population of 1.4 billion. Nothing can be rare in India, isn't it? So the Immune Deficiency Society of India said we have more than 1 million patients with primary immune deficiencies, and most of them are yet being undiagnosed or underdiagnosed, and it is responsibility of each one of us in this hall to diagnose them in time. And do you know, as a group, these immune deficiencies are 4 times more common than hemophilia and 5 times more common than cystic fibrosis. So each time your professor in the round says, recurrent pneumonia, think of cystic fibrosis, please tell them, sir or madam, let's think of immune deficiency, it's 5 times more common. That's the reality. Let's go quickly to cases. What I'll do is I'll present a few real life cases and bring to your spectrum what's think zebra. First case, no T cells. This is a 9-month-old boy, came to us with chronic diarrhea for 3 to 4 months, not responding to several antibiotics. This child had been hospitalized in at least 3 hospitals with repeated episodes of culture proven sepsis, and he had persistent oral thrush. So looking at this, I'm sure each one of you would think something is wrong with this child. There is diarrhea, there are multiple episodes of infection, and then there is candidiasis, which is an opportunistic infection, isn't it? Then when we looked at the chest radiograph, it did show pneumonia, but the thymic shadow was completely not seen. So when you don't see a thymus, start getting worried, because in young children, thymic shadow is easily visualized on a chest radiograph. On the hemogram, what was striking was there was neutrophilic leukocytosis. The resident there said this is sepsis. I said you are right, but only partly, because you have not looked at the lymphocyte count. Please look at the lymphocyte count. The absolute lymphocyte count is only 1200. Any lymphocyte count less than 3000 in the first 2 years of life is lymphopenia, and persistent lymphopenia with this clinical picture, there is only one diagnosis, and that is severe combined immune deficiency. This is one group of disorders that will present in infancy with a lot of infections. They don't thrive well because of repeated infections. What they don't have is the T cells. So the next step is to get a T cell count on the lymphocyte subset assay, and you will see that the T cells are very low. So young infants with severe pneumonia, oral thrush, failure to thrive, think of this disease. This is a fatal condition. You don't diagnose them, all of them will die within 1 or 2 years. So often you will get the history of early sibling deaths. The family will say, first child died, I don't know what was the cause, doctor said malnutrition, sepsis, the second child is not doing well. Think of an immune deficiency. Suspicion on your part, look at the differential counts. If there is lymphopenia, the chest radiograph is not showing thymus, then you have virtually made a diagnosis of severe combined immune deficiency. These children need urgent referral. Why? Because what they need is a bone marrow transplant. This is the perineal rash that you see pre-transplant and post-transplant. As the child recovered, the rash and everything healed. And this is the discharge picture where mother is the donor for bone marrow transplant and the child is currently doing fine. That's case number 1. Now moving to case 2, intermittent neutropenia. We have been trained by our professors, that teachers, that always look at differential counts. Very much in the first case you could see lymphopenia can be picked up only if you see differential counts. The total WBC counts carry no meaning. Let's look at the second case. A 3-year-old boy from Bangalore who was ventilated for 17 long days at 6 months of age at some hospital in Whitefield, Bangalore. This child had severe pneumonia, possibly I think it was PCP pneumonia at that point of time. The treating team did an excellent job, the child recovered. At 1.5 years of age, another episode of pneumonia, and now this child was being followed up as a case of hyperreactive airway disease and being given inhalers. Now when we reanalyze the records when the child was referred to us, this was interesting. At 6 months and at 18 months, when the child was hospitalized, on both those occasions, the neutrophil counts had significantly dropped and there was neutropenia, but all throughout the WBC and ANC was fine. So 2 episodes of neutropenia, multiple infections, something was going on, we did a immunoglobulin profile. And as you can see here, IgG and A are undetectable, but the IgM is very high. What do we call this? The hyper IgM syndrome. This is a group of conditions where the body does not produce other immunoglobulins except for IgM. So these patients are known to have episodic or persistent neutropenia, at least in half of the situations, and if you give a growth factor called GCSF, their neutropenia tends to respond. So whenever you have neutropenia and recurrent infections, please get an immunoglobulin profile. And this group of disorders, which is hyper IgM syndrome, can definitely have neutropenia that responds to exogenous therapies. What did we do? We gave this child a new life by doing a haploidentical bone marrow transplant with mother as the donor. Case 3, suppurative infections. Now this is a 2-year-old boy, came from Kola, who had at the age of 1 swelling of both the feet and high grade fever. Fevers going on for at least 4 weeks, and when radiographs were done, as you can see, there is osteomyelitis involving small bones. There is osteomyelitis involving the small bones of the feet, and the treating team then gave IV antibiotics almost for 8 weeks for this infection to resolve, only to see that 6 months later this child came back to them with suppurative lymphadenitis, draining pus, and the culture showed Staphylococcus aureus. With this second infection, the pediatrician got worried, said something is going on, referred, and then when we saw there was marked neutrophilic leukocytosis, thrombocytosis, and since we thought it is immunodeficiency, we got an immunoglobulin profile. You can see the immunoglobulins look okay. In fact, they don't look okay. They are very high. They are markedly elevated. So that is hypergammaglobulinemia. So should I stop here? Immunoglobulin is high. The child is protected. That's not the answer. We got what we know as NBT dye reduction test, the nitroblue tetrazolium dye reduction test. This is a simple test that helps you determine the neutrophil function. You stimulate the neutrophils, and if you see this pigment formation, this is normal. If it is not formed, it's abnormal, right? Neutrophils, how do they kill organisms? For all undergraduates, we all know there is a step called phagocytosis, isn't it? And after phagocytosis, there is intracellular killing. In this disease, the intracellular killing is problem. What's the disease? That's chronic granulomatous disease. And what did we do? We again offered a bone marrow transplant, and 6 years down the line this child is doing fine. So CGD can present with small bone osteomyelitis, and we went on to publish this case report. So chronic granulomatous disease is a disease where you can have lot of pus forming infections, suppurative lymphadenitis, non-resolving pneumonia, a lung abscess or sometimes a liver abscess, and if you have ongoing severe infections that don't respond to antibiotics just like they should do, think of chronic granulomatous disease. A simple test like NBT can pick up the diagnosis. What's the cost of the test? 300 rupees. In Bangalore I'm talking about. So these are very cost effective tests. Let's go to the next case. Very high counts. So this is an 8-month-old girl coming from Tumkur. This young girl had recurrent ear discharge right from the first month of life and 2 episodes of pneumonia. And when the girl was referred to us, you can see the hemograms. There was marked leukocytosis, almost touching 90,000, some records crossing 1 lakh. And then it was all neutrophilic. The treating doctor thought, is this leukomoid reaction? But this is all neutrophilic. And this you should not think of leukemia when you are looking at neutrophilic leukocytosis. What do you think when you have such degree of neutrophilia? Yes, that's the answer. Leukocyte adhesion deficiency. Did I do any blood test immunological here? No. And yet you can make a diagnosis, because there is hardly any condition that will come with so many infections and 1 lakh WBC count, which is neutrophilic predominant. And we offered a bone marrow transplant, and the child is currently doing fine. So what's leukocyte adhesion deficiency? You all know this is the bloodstream, this is the endothelium, and this is a tissue invasion with a microbe here. So whenever there is an invasion, the leukocytes are supposed to adhere to the endothelium, leave the bloodstream and come and phagocytose. So I think all of you have read Inflammation, Robbins, chapter 2. And you have read all this, isn't it? Rolling, adhesion, transmigration, so many terms. That does have a clinical relevance here. Here the neutrophils are missing something called CD18. Now they cannot stick to the endothelium. All the neutrophils are in the blood. So you get very high neutrophil counts. There are no neutrophils in the tissue to fight infection. And so these patients don't form pus. So when you see such a picture, that's leukocyte adhesion deficiency. Next case, diarrhea that does not stop. A 1.5-year-old boy comes to us with recurrent diarrhea from 8 months of age, blood in stools, given lots of antibiotics. Now when we examined, this child had already developed a perianal fistula. The moment we saw fistula, we involved our pediatric gastroenterologist, Dr. Jayalakshmi, and then she did an endoscopy and said, oh, the biopsy shows something like Crohn's. We are saying Crohn's is IBD, and IBD in a infant, that's so uncommon. So what do we call this? Very early onset IBD. IBD that starts before the age of 6. And remember, if you have IBD at that age, it's uncommon, but it is almost always monogenic, a genetic defect. So we did a genetic study, there was a mutation in the IL-10 receptor defect. So gene. Now tell me one thing, if somebody has IBD, what's the treatment? You give steroids, you give immunomodulators, and you treat them for life, or you keep them in follow-up for life. There is no cure. But if you have IBD because of IL-10 defect, you can cure them by doing a bone marrow transplant. Now that's the difference. You offer a cure to a child with IBD. And this is in fact a child who traveled all the way from Gujarat to get a transplant done at a center. So IBD is lifelong immunosuppression, but if you have IBD because of IL-10 defect, as in this case, you can cure them with bone marrow transplant, and that's what I call precision medicine. You treat what is required. You give what is required. Next case, SLE starting at a very young age. Now this is a 13-year-old girl from Mauritius, had SLE at the age of 2. You can see classical malar rash, discoid rash, alopecia, and class 4 lupus nephritis. What is odd? SLE often in children also starts beyond the age of 8 or 10. Here the lupus is starting at the age of 2, very early. And then positive family history, a consanguineous background, and then the second girl had in fact died of pneumococcal meningitis and pneumonia. So we thought this has to be a genetic problem. There is a death in the family, there is consanguinity, and then this child is having unusual lupus. What does consanguinity tell you? What group of disorders? As residents, you should know consanguinity means increased risk of autosomal recessive diseases. And I can tell you in certain segments of North Karnataka, because I belong to this region and I have done clinics here, lot of consanguinity is seen in certain populations. And that is why you see a lot of neurometabolic disorders, the IEMs, and you see a lot of IEIs. So what did we do? The ANA was positive, the complements were normal, CH50 was very low. This is C1q deficiency, complement C1q deficiency that is presenting with early onset lupus. And the child who died with the pneumococcal sepsis also possibly had that. Why? Because what is pneumococcus? It's a encapsulated bacteria. And how do you get protection from encapsulated bacteria? By doing opsonization. So opsonization is a process by which our body clears such bacteria, and C1q is an opsonin. So if you have C1q deficiency, you will get increased risk of pneumococcal infections. Again, interestingly, complement proteins are all produced in liver, but C1q is one protein which is produced in bone marrow stromal cells. So what can you do? A bone marrow transplant, and you're right, and that was the first bone marrow transplant for a C1q deficiency child that we could offer. So think of a C1q deficiency if onset of lupus is before the age of 5. Generally anti-DSDN is absent. There could be a family history of recurrent infections with encapsulated bacteria. Recurrent pneumonia and eczema. Now you all know eczema is often seen in dermatology clinics where children are treated for atopic dermatitis. But this child beyond eczema from 5 months of age had empyema that needed drainage, then an inguinal abscess at 8 months of age, left lung abscess, aspergillus pneumonia at 6 years of age. In fact, small lingular resection was done, and then MRSA pneumonia. This child actually was shouting, I have an immune deficiency, isn't it? So then IgE was markedly elevated. The genetic test is positive for the STAT3 gene. We call this as the autosomal dominant hyper IgE syndrome, previously known as the Job syndrome. And what did we do? We offered a bone marrow transplant with this kind of conditioning regime. I don't think we need details of such conditioning regime here. But then finally this child is cured, and now 7 months down the line this child is doing fine. The last case here, lymphadenopathy for years in a local boy. Why do I call a local boy? 3-year-old boy, very much from Dharwad. I saw this child almost 6 years back. Multiple enlarged cervical nodes from 2.5 months of age. Increased size of nodes for last 6 months at the age of 3 months, generalized lymphadenopathy and splenomegaly. This lymphadenopathy was going on for months and years. So obviously when you have lymphadenopathy, you would think of say infection, TB, leukemia, lymphoma, but this is going on for years. HIV was negative, On the LFT, there was AG reversal, globulins were high, there was hypergammaglobulinemia, and somebody had done a lymph node biopsy which was said to be reactive. So we had no clue what we were dealing with. What we were dealing with was chronic non-malignant lymphoproliferation. This is not malignancy, there is hypergamma and no infections. This is what we call ALPS, the autoimmune lymphoproliferative syndrome. You all know in our body, cells take birth, cells die. What is the natural process by which cells die? Apoptosis. So here there is a defect in apoptosis. So those lymphocytes are not dying, they are just multiplying, causing lymphadenopathy, organomegaly, and sometimes autoimmunity. How do you diagnose? You do something called double negative T cells. You all know T cells are CD3 positive. There are so many students here, I'm sure you all know that. But there are two types of T cells. Helper T cells which are CD4 positive and cytotoxic T cells which are CD8 positive. Double negative T cells are both CD4 and CD8 negative. And if you have elevated double negative T cells, that's the diagnosis for ALPS. And that is why I was talking about zebras. When you hear of hoofbeats, just don't think of horses. Do think of zebras. And this is not my statement, this is a statement from the IDF, the Immune Deficiency Foundation, which says this is their logo, think zebra, right? And if we all start thinking of zebras, these children will be diagnosed much earlier. I'll quickly touch upon my objective number 2. And what was that? Chimera, right? I'm happy you all remember. Let's see, what's a chimera? We all know our blood cells in our body are, the origin of all these blood cells come from, the hematopoiesis is from the bone marrow, which has got stem cells. So the stem cells give rise to white blood cells, red blood cells, platelets. So it makes sense that if I do a bone marrow transplant, which should be actually called as a stem cell transplant, you should cover or cure blood cell disorders like red blood cell problems, like thalassemia and sickle cell anemia. We all know can be cured by doing a bone marrow transplant. The same is white cells. If your white cells are in problem, if there are no T cells, if there are no neutrophils, like conditions like SCID, conditions like congenital neutropenia, conditions like CGD, all of them can be cured by doing a stem cell transplant or a bone marrow transplant. So what's the process? It's simple. It's not simple, but here I've made it simple. So here you have a donor. We try to get a HLA matched donor. You collect stem cells from the donor. There are mechanisms. And then to the patient you give chemotherapy because you just want to wipe out all of their stem cells. And then you infuse the stem cells from the donor, and that's bone marrow transplant. What happens in this process is, you can see this is the donor DNA, this is the stem cells from the donor, and this is the recipient who has got her own DNA, right? After we do a bone marrow transplant, it looks something like this. All the cells in the body are recipient, but the blood cells, the white blood cells, the red blood cells, the platelets, and naturally the immune system is all of the donor. So within the same individual, now you have DNA from two different individuals. The hematopoiesis and the immune system belongs to the donor, but the other tissues, say you do a buccal swab DNA, it's still of the host. That is what is a chimera. So after a transplant, your child becomes a chimera, and we prefer having a full chimerism wherever possible by doing a bone marrow transplant. So by making them a chimera, you cure, and you cure SCID, hyper IgM, CGD, LAD, C1q, VAS, the viscotality syndrome, and many more. So, and these are the few pictures from the clinics where we have offered bone marrow transplant, and fortunately most of them are doing fine. Often when I talk about this, I get two favorite questions. First favorite question is, can we do these tests immunological when the child is having infection? Please do the tests. If the tests are grossly abnormal, you have made a diagnosis, give treatment. If the immunoglobulins are low, if you don't give IVIG, the child is not going to recover. And you can always repeat the test if the tests are borderline. The second question they ask is, what is the cost of a bone marrow transplant? And the answer here is, we offer affordable BMT. The question is not what is the cost, the question is who pays what. And definitely there is a patient expenditure, but then there are other platforms of crowdfunding, CSR, corporate social responsibility, commitment from the hospital, through which we can run a low cost, high volume, high reward model, through which we have been able to recently cross 60 BMTs in PIDs in our unit. And as I speak, this is our team at Manipal Yalanka. We've started or restarted a journey, and we seek your support, and most of them are here today to speak with you. Once again, thank you for the opportunity. This is a small book. This is a small book. I have got a few copies of this book. This is actually a small handbook. I'm sure some of you have read it. It's Immunodeficiencies Made Simple. With your permission, I'll gift it to the IAP here, and then they can circulate. And last but not the least, I invite you to a meeting, a immunotransplant summit that is called the Manipal Immunotransplant Summit, happening in April 25-26. It will be Saturday evening and Sunday morning. We'll only and only discuss cases. I promise you 80% of the conference will be case-based conference. I have invited Professor Surjit Singh sir, my mentor from PGI Chandigarh. Unfortunately, he's coming. Couple of international faculty and more than 15 to 20 national faculty have agreed to join this meeting. I invite all of you to come and join us in Bangalore in the last week of April. Once again, thank you.
Thank you, Dr. Sagar, for making it look so simple. Things that look difficult, things like look beyond our capabilities. This is a person who makes it very simple. Even when I just started my practice, I was not able to get into these technicalities of the things. I used to call him and ask him, what are the basic tests that a pediatrician should know to send if he or she is suspecting an immunodeficiency? So if you can elaborate on that panel, a small panel where you can get to a diagnosis, some small diagnosis. Otherwise, the ocean is vast. So it becomes very difficult, and by reading that book, I came to know that for these diseases, you'll have to have these specific tests, and you can paste them or cut them and keep them on your table. So whenever you have an opportunity, you can send those tests. So if you can highlight few of the tests commonly seen immunodeficiencies, what are the basic tests for the postgraduates, so that would be helpful. And that is how he makes things look so simple. And when I got my first diagnosis of immunodeficiency, I called him and I thanked him that I read your book and I could get this diagnosis which was in front of my eyes, and I could not recognize that because we had been treating that as a case of pneumonia, admitted twice or thrice. So we got that diagnosis. So
yes, sir. Thank you, sir. I agree with your point that the ocean is vast. As I speak, we are touching 600 diseases, and sometimes it is overwhelming. But to keep things simple, I think the first step to diagnosis is suspicion. Any pediatrician, any clinician, or any student who starts thinking, could this be immune deficiency, you have cracked the diagnosis. Because once you arrive to that thought, you're going to work up. Step 2 is, please look at your differential counts. If there is neutropenia, it could be congenital neutropenia, for example. If there is marked neutrophilia, like 1 lakh neutrophil counts, that is leukocyte adhesion deficiency. That's step 2. Step 3, I would say, is serum immunoglobulin profile. If you have recurrent pulmonary infections, recurrent ear discharge, the simplest test could be to do an immunoglobulin profile. And if you get low immunoglobulins, a large chunk of immune deficiencies will get diagnosed with the immunoglobulin profile. The next step could be, if the profile of infections is lot of pus-forming infections, like suppurative lymphadenitis, lung abscess, liver abscess, do a NBT or a DHR. So these are the tests I would recommend. And then to simplify life, when I started my practice in Bangalore, I asked a lab, not the scientific way, but I said, let's do a PID panel. And that panel had immunoglobulins, NBT, DHR, and lymphocyte subsets. And that's all you need actually as a clinician. And most pediatricians then started using PID panel. Today, as I sit in my OPD, I don't write PID panel because most patients come with the report to me with already tested a PID panel. So either you can use that panel or you can do immunoglobulin profile, lymphocyte subsets, and the NBT DHR. The last but not the least, today the diagnosis rests on genetic testing. And as I speak, exome sequencing is now readily available. There are too many labs, that's the problem. The standard of those labs is a question, but the cost of exome sequencing has come down significantly, as low as 6,000 rupees as I speak. So no longer can anybody say, my patients are poor, I cannot test them. Cost is not prohibitive now. It is all in our minds. If we think, we will diagnose these conditions.
So basically, we used to get patients who used to get reports of CBC, chest X-ray, ultrasound, and come to the pediatricians for the opinion because the peripheral doctor could do that and then send. And now, in coming days, probably we'll be getting the reports of whole exome sequencing to you for your opinion on that genetic panel or the gene what is abnormal. So now we'll have to, life made easy probably, get the reports, you just have to answer their questions, and to do that, you'll have to be much more skillful and knowledgeable than what you were earlier. So big round of applause to Dr. Sagar once again. Thank you for coming and giving us insights on the immunodeficiency thing. Thank you so much.
Thank you.
We'll go to the next speaker.
Thank you so much, sir. That was a very wonderful talk. You made such a complicated topic so easy and interesting. Coming to the next speaker, our next talk is on insulin pump therapy, advancing diabetic care in clinical practice. Diabetes management has evolved significantly over the years, and remarkably, technological innovations such as insulin pump therapy have transformed the way we approach glycemic control, particularly in children and adolescents. We are now honored to have with us today Dr. Shyam Kiran, an expert in pediatric and adolescent endocrinology. Sir has completed his MD in pediatrics and further pursued a fellowship in pediatric and adolescent endocrinology from the prestigious institute, Indira Gandhi Institute of Child Health, Bangalore. He currently serves as associate consultant in pediatric endocrinology at Manipal Hospital, Yelahanka. Prior to this, he has worked as a senior registrant in pediatric endocrinology at Splash Hospital and Astor Hospital, where he has managed a large number of cases. Dr. Shyam Kiran's key clinical and research interests lie in diabetic technology and children with type 1 diabetes, including insulin pump therapy, continuous glucose monitoring, and technology-driven optimization of glycemic controls. He has authorized peer-reviewed publications, serves as a reviewer for annals on pediatric endocrinology and metabolism, and he has presented his research internationally at International Society of Pediatric and Adolescent Diabetes 2023 at Rotterdam, as well as national conferences. His ongoing researches focuses on evaluation of insulin dosing adjustment A1C for early identification of honeymoon phase in newly diagnosed type 1 diabetes. I kindly welcome you, sir, for your talk on insulin pump therapy, advancing diabetic care in clinical practice. Over to you.
Thank you for that warm welcome. So the reason for choosing this topic today, as we all know that we are entering into the era of AI and technology, and a lot of this diabetes management has become a technology driven aspect as of now. So today my talk will include the principle of insulin therapy, components and types of pump, indication and selection of candidates, and how do we initiate and monitor the insulin pump, pros and cons, and we'll share our experience. So in order to understand the principle of insulin pump, first we need to know how the blood sugar is regulated in our body. So during the fed state, like as when we take the food, there is a spike in the blood glucose. So this glucose will trigger the beta cells to produce the insulin. So insulin will facilitate the movement of this glucose into the muscle, adipose tissue and liver. Similarly, when there is a fasting state, when there is low blood glucose, the insulin will get switched off, and the glucagon, which will mobilize the glycogen from the liver and maintains the blood glucose. This system works in a perfect computer algorithmic fashion, maintaining the glucose homeostasis. But in case of type 1 diabetes, this regulation is disrupted. Why? Because there is an immune mediated beta cell destruction which leads to the insulin deficiency, and we have to give an exogenous insulin through the multiple daily injections. So this is not always matched with the carbohydrate intake that we do. Sometimes it will lead to the overcorrection and undercorrection, leading to hypoglycemia and hyperglycemia. Most importantly, when there is a hypoglycemia because of excess insulin, the glucagon is not stimulated. That will cause profound severe hypoglycemia. So our clinical challenge in achieving the tight glycemic control according to our ISPAD guidelines, that is the International Society for Pediatric and Adolescent Diabetes, they say the HbA1c should be less than 7 and the glycemic variability should be less than 34%. So what do I mean by glycemic variability is the day-to-day variation in our glucose. So that should be less than 34% to have a complication-free life. But this is very challenging with the multiple daily injections and the glucometer blood checks. So when the researchers, innovators and the scientists come up with an idea, so that was the insulin pump. So when they went deeper into the research, they found out a very interesting pattern about the insulin secretion from our beta cells. So it is secreted in a biphasic manner, meaning there is a basal pattern which is continuously secreted from the beta cells, and there is a bolus pattern. As soon as we take any food and there is a glucose spike in our body, the bolus insulin is released by the normal beta cell. So they initially proposed a basal bolus regimen, which is widely practiced. So the basal pattern, it is matched by giving the long-acting insulin like the glargine, detimer, NPH and degludec, and the bolus insulin is matched by giving our ultra short-acting and short-acting insulin, that is the regular insulin, Novorapid, Fiasp and glulysin. So with that basal bolus regimen also, the HbA1c was somewhat controlled, but it was not under the recommendation of less than 7. So the next idea was the insulin pump. So what do you mean by an insulin pump is a small device which will pump continuously the insulin into the body through subcutaneous plane, and which will adjust the basal rate and also the basal rate according to the CGMS readings. And just like pancreas, the insulin pump also has only one type of insulin, that is the short-acting insulin or the ultra-short-acting insulin, that is Novorapid or Apidra that we will use, thereby mimicking almost 90 to 95% like a pancreas. So to put it in simple terms about the diabetes management, managing the diabetes with the multiple injections and checking with the glucometer is like driving your Maruti 800, which is a manually driven car. When you need to apply the clutch, you need to change the gear and you need to change the steering. So when you're managing with this multiple daily dose of injections and glucometer, you need to take a lot of decisions like carbohydrate counting, insulin carbohydrate ratio, how do you manage the hypoglycemia, hyperglycemia, etc. So in a type 1 diabetes person, he makes close to 200 to 300 decisions alone about his type 1 diabetes. So which in a long term will lead to something called as diabetes fatigue, which will negatively impacts the diabetes management. So with the advent of CGMS, so that is a continuous glucose monitoring system, which is a small device which is inserted over the arm, it continuously monitors the interstitial glucose and gives the readings. So with the advent of this, the glycemic management or the diabetes management has become somewhat easier. So it is just like driving an automatic car. But with the advent of insulin pump, which takes into account of your CGMS and the insulin pump, is like driving a Tesla, which is a self driven autopilot car. So you just put your type 1 diabetes management into the autopilot mode and don't worry about it at all. So next, coming to the components and the workings of an insulin pump. So here we have the first important component is the CGMS. Like I said, it is a small device which is either inserted over the abdomen or to the arm. So it gives the values continuously every 5 minutes, and this is the insulin pump here, which houses the insulin reservoir. So this is where our insulin stores for 3 days, and this is the tube where the insulin is delivered, and this is the insulin patch. It's a small subcutaneous cannula which delivers the insulin every 5 minutes according to the CGMS readings. So the CGMS will give the readings to the pump. So the pump will give the insulin to the subcutaneous and the body will react. So that is taken up by the CGMS again. So this forms a closed loop, and hence it is called as closed loop system. So coming to the evolution of insulin pump. So insulin pump, all the discovery and the invention started long back in 1970s, where they had this backpack insulin prototypes, meaning the insulin pump used to be our infusion pump, just like how we use in PICU and NICU. And by 1980s, the pump has become really, really small because our chip size has decreased and our computing power has greatly increased. So the pump has become really small. And by the 2010, they have integrated this CGM into the into the pump, so that the pump will get suspended whenever there is a low glucose. And coming to next in 2020, they have come up with something called as hybrid closed loop system, which will continuously adjust the basal rate according to the CGMS readings. So these are some of the examples of the older pump. So this is the backpack prototype pump, and this is in the 1980s they have made it very small, and this is in 2010 it has come a sensor augmented pump by the Medtronic. And these are some of the newer pumps. This is the advanced hybrid closed loop system, that is 780G, which is available in India. So this is beta bionic. It has two hormones, that is insulin and glucagon in it. And this is Nick Jonas flaunting his Omnipod 5, which is a tubeless pump. So coming to the indication, like for whom we can start insulin pump, means basically anyone who is highly motivated to go on an insulin pump from 0 to 80 years of age, we can put them on insulin pump. Apart from that, anyone who is having poor glycemic control or existing diabetes complication like retinopathy or nephropathy, or someone is having brittle diabetes, meaning if you give a 0.5 unit of insulin, the sugars will drop to 70 or 60, and if you don't give, the sugars will spike to 500. So in that situation also we can go for pump. And someone who is having severe hypoglycemia and hypoglycemic unawareness, so these are the candidates who can go for insulin pump. And the contraindication is patients or family who lacks the motivation to go on or to manage the pump are the only contraindication. So once we select, decides to go on a pump, we need to select the candidates. So to select the candidates, the person must have a total daily insulin of more than 8 units, and they should be highly motivated to learn that skills like carb counting, insulin carbohydrate ratio, how do we manage in cases of emergency, hypoglycemia, hyperglycemia, etc. And they need to demonstrate responsibility in device care and maintenance. So one of the important thing is sensitizing the patients early in the course of the disease will vastly increase the acceptance and the outcomes. So once we select the candidates, we sit with them. We call the Medtronic's diabetes educator, so to the OPD. So we will teach them, we'll teach the parents and the patient like how to change the infusion set, the CGMS. The infusion set needs to be changed every 3 days, and the CGMS should be changed every 7 days. And we will tell them like how to change the battery, the reservoir, and we'll teach them the insulin carbohydrate ratio, how to do the carb counting, what to do in case of emergency like hypoglycemia, hyperglycemia, how to take care of the pump, etc. So once they pass all these things, once they accept to go on to the pump, so for initial 48 hours, we need to set something called as basal rate. So the pump will be in the manual mode. After 48 hours, the pump will go to something called as autopilot mode. So to determine the basal rate, first we will calculate what is the total daily dose the person is taking. Suppose if the patient is taking 10 units of insulin per meal, that will be 30 units and plus 20 units basal. So when you are switching to the pump, so the person requires around 20 to 25% lesser than what he is taking. So 50 units, it will become 40 units, the 20% of 50 units will be 40 units. Then we will divide it 50-50 according to the basal and the bolus. So the 20 units will be the basal, and we'll divide it into over 24 hours. So the basal rate will become 0.8 units per hour. And we'll tell the patient to calculate the carb, so in the each food, and to set an insulin carbohydrate ratio of initially to begin with 1:15. And the pump will calculate how much the bolus the person needs to take. He just needs to input only the carbohydrate, like how much he is going to take. And we'll set various other parameters like active insulin time. So this is the duration of the insulin which is there on board on the in the body. So this depends on the pharmacodynamics of the insulin, the type of insulin that we are using. So right now we can use only 2 insulin, that is Novarapid and the Fiasp. And second thing is we set the target blood sugar, so that is different to each pump. And we'll set the few alarm settings like hypoglycemia settings, like we need to alert the patient when they are having hypoglycemia or hyperglycemia. So once we install or like initiate the pump to the person, we will tell them not to do anything, just to input the carbohydrate when they are going to eat. And after 48 hours, the pump will take its own course. It will go on to the autopilot mode. So the data will be uploaded to the cloud server that is called as Medtronic Care Link, and will take the consent of the patient to remotely monitor and surveil the blood sugar day to day. So this is how an ambulatory glucose profile of a person looks who is on an insulin pump. So this is for around 90 days, that is 3 months. So this belongs to a patient X who is 17 years old, diagnosed with type 1 diabetes for 10 years of age, and he is on Medtronic 780G pump for 2.5 years, and his recent HbA1c is 6.5. So when we do the post-mortem of this report, so there are so many parameters involved. So one important thing is the time in range. So what do you mean by time in range is the percentage of time that a person spends in a 24 hours between the blood glucose range of 70 to 180. So according to the ISPAT, they say more than 70% will lead to a good glycemic control. So this person has around 85, which is good. Then we'll go into various statistics, that is smart guard, that is how many hours in a week the person is on the autopilot mode. It should be more than 90%. And we should also see what is the percentage of time he is on the sensor, that is also should be more than 90%. And we'll look into GMI. So GMI is a derived index. So it is derived by the various parameters of the CGM and the pump. Through the mathematical equation, we'll derive the pump itself, it will give the GMI. So the various studies have described the GMI, the 3 months average GMI will closely resemble the HbA1c. So here you can see the GMI is around 6.5, and this person HbA1c was around 6.6. So the GMI closely resembles the HbA1c. And also we'll see what is the total daily dose the person is taking, and we'll also see what is the auto correction percentage, meaning the how much pump is working. So if the pump is working or taking care more than 50% of his diabetes management, then we need to intervene, then we need to change the carbohydrate ratio, adjust the active insulin time, etc., like that. So, and coming to the graph, here you can see this dotted line. So this is the average blood glucose, and we like to keep the average blood glucose between 180 to 70 mg. So this is the time in range. And the shaded areas, that is the blue and the orange shaded areas, represents the 25 and 75 centile, and the 5th and 95th centile are represented by the dotted lines. So when we look into his pattern, his average line is in the range between 70 to 180, and he has occasional events of hyperglycemia, which is mostly happening between around 8 to 9 a.m. okay, and then again at 5 to 4, and again at between 8 to 7. So when we looked into what is the reason, so when we went back and we saw his all the log books, food logs and all, we found out that he is having a cortisol response. There is a stress response which is causing morning hyperglycemia, which is leading to the pump is overreacting and causing overcorrection, and which is leading to hypoglycemias. So as is evidenced by the pump, it is telling that there is a hypoglycemia before lunch. So he is overcorrecting his hypoglycemia, and again it is causing the hyperglycemia in the evening. So this is how a day-to-day graph looks. So this pink, this thing are the basal rate, which is automatically adjusted by the pump according to the blood glucose. So this green area what you are seeing is the timing range, that is between 70 to 180. And this green line what we are seeing is the target blood glucose. So based on this green line only, pump tries to get the insulin to this line. And these purple dots are the auto correction, which is the feature present in the advanced hybrid closed loop system. And this is the manual or the user given bolus, like he has to calculate how much amount of carbs he is taking, and the pump will calculate that he needs to take 10 units, and the 10 units will be delivered. And this is the active insulin time. So during the active insulin time, the pump will not do anything, it will not give any basal insulin as such. So looking at his this thing day-to-day graph, we advised him to have breakfast before 8 a.m. so that the cortisol response will be blunted, and to give a long gap between the bolus and the breakfast. So to give the insulin to have effect, and we have increased the active insulin time from 2 hours to 2 hours to make the pump less aggressive in between the meal time. So the pump has its own complication. So as we all know, the pump has only one type of insulin, that is the short-acting insulin. So any tube kink or any the insulin getting depleted or any mechanical failure will lead to rapidly develop the DKA. So that carries one risk. And they can also have dermatological issues. Means insulin being an anabolic hormone, it causes something called as lipohypertrophy. Means it will, the adipose tissue or the subcutaneous tissue will become very hard, and the insulin may not get absorbed properly from there. And also they are exposed to various skin allergies because of the adhesive which are present in the insulin patch and the CGM. And with the dangerous use like causing physical damage and all, it always carries a risk of the hardware damage. So when evaluating the pros and cons, so obviously the clinical advantage is the pump mimics around 90 to 95% of a healthy pancreas. It gives total freedom from all the decisions in a life of a type 1 diabetes, and it also leads to superior quality of life, and it leads to a complication-free life. So when we come to the cons, so the trade-off being the foreign body sensation. They always feel like, okay, there is something on my body. But all our patients, they told like within 2 to 3 weeks, they have outgrew this condition, and they carries a slight increased risk of having an infection, but it is preventable by maintaining the regular hygiene. And one of the biggest thing is the high financial barrier. So the initial device itself cost around 6.5 lakhs, and the recurrent consumables is around 20,000. So when we compare to the massive economic burdens of diabetic complication, the pump seems like a better option. So if a person is managing his diabetes with the multiple daily injections and the glucometer check, obviously he is going to spend less than 1 lakh per year on his diabetes management. But that will lead to the suboptimal HbA1c, and he carries an increased risk of complication. And managing this complication in the future, it's going to be an economic burden on him. So with growing the healthcare cost, it's going to cost a lot of fortune for him to manage those complications. So going on a pump is like investing in your mutual fund. Initially you might not feel the benefit of the pump, but over the growing years you're going to reap massive benefits in terms of complication averted and with a great quality of life. So with that, the Ministry of Health and Family Welfare, the Government of India, has proposed a scheme, that is CGHS scheme. So any parent who is a central government employee, be it DRDO, ISRO, or railways, or in the defense, they're going to give the reimbursement on the pump for up to 3 lakhs and on the monthly consumables of 5,000. Also, we have EMI option, which is provided from the third party financiers. So to conclude, so injections are cheaper per year, but complications are expensive for life. A pump is like insurance you actively use every day. So to share our experience, so this is our pediatric endocrine team at Manipal Yelahanka, led by Dr. Kavita Bhatt and Dr. Namrata Upadhyay and myself. So we have around 300 to 350 patients, type 1 diabetes patient, attending our comprehensive diabetic clinic, where we walk through them through the CGM initiation and insulin pump initiation and monitoring. So, and also we give them a comprehensive diabetes education and also management. So we have around 15 kits on 780G, that is advanced hybrid closed loop system. So, and the median age of our children are around 10.2 who are on pump, and they have an excellent HbA1c of 6.8, and all of them, 100% of them are satisfied with their HbA1c. So when we asked about their quality of life, they said all of them are free from their, especially the parents are free from their clinical decision making. And among 10% of them, they told there is a restriction in their physical activity while sleeping and while playing, etc. So when we asked them to rate the happiness score from 0 to 10, so their average score they rated around 8.71. So with that, I would like to conclude my talk. Thank you.
Thank you, Dr. Shamkiran, for the wonderful enlightening talk on the insulin pump. Because as pediatricians, definitely we will be seeing 1 or 2 cases of type 1 diabetes in a year, or probably more in a year. But the problem comes how to adjust the insulin dose, when to give, how to give, what are the stages, how to calculate. So these are the basic practical problems that we, as a pediatricians, we generally encounter. So with this vast knowledge, then probably having this as your go-to to reduce the number of pricks for the child. So that is one of the things that you should understand, you should know. But again, you need to have a help from your team members, from the endocrinologist at your place, and that is how we can make the life of the child much simpler and easier without the many pricks. So just a question, at what age can we have that GCMS CCGMS install, I mean, put on the body?
You can start from even from 0 to 80 years, sir. So you can start in the neonatal period also. So right now, even for the congenital hyperinsulinism, so for that babies also we'll use the CGMS.
And how effective is it compared to your routine glucose monitoring?
Definitely. So there is something called as MARD. So that is called mean average relative difference. So the MARD is only about 9%. Means if you check in a sensor and a glucometer, it gives only a difference of 10 milligram per deciliter of the blood glucose. These things. So it is very, very effective. One, in reducing the number of pricks, and also it gives you when the baby is going into the hypoglycemia or the hyperglycemia, and it has all the trends and arrows. So we can preemptively take a decision and avoid all those hyperglycemia and hypoglycemia episode, which may not be as effective when we do the blood glucose with the glucometer.
So any other questions from the postgraduates, staff? So if there are no further questions, then we'll break for a small tea break, and then we'll come back after 10 minutes. Is that okay? So we'll break for a tea break, and then we'll come back.
Welcome back, everyone. Our next talk is titled Stories of Hope and Healing Lessons from Pediatric Oncology Ward. Pediatric oncology is a field that not only demands clinical expertise but also immense compassion and resilience. Each child's journey through diagnosis, treatment, and recovery brings valuable lessons of courage, perseverance, and hope for both families and healthcare providers. We are honored to have with us Dr. Aarti N., consultant in pediatric hematology, oncology, and bone marrow transplantation at Manipal Hospital, Yelhanka, Bangalore. Dr. Aarti completed her MBBS and MD in pediatrics from PGI Jipmer, followed by DM in pediatric oncology from Kidwai Memorial Institute of Oncology, and further training in bone marrow transplantation at Apollo, Chennai. She brings with her over 12 years of experience in pediatrics and more than 9 years of dedicated experience in pediatric hematology and oncology. Her areas of expertise include blood cancers, relapsed leukemia, pediatric solid tumors including brain and eye tumors, bone tumors, hemoglobinopathies such as thalassemia and sickle cell anemia, aplastic anemia, and bone marrow transplantation for refractory cancers and bone marrow failure syndromes. On behalf of everyone present here, I warmly invite Dr. Aarti N. and invite her to deliver her talk on stories of hope and healing, lessons from pediatric oncology ward.
Thank you. Good afternoon, everyone. So I don't have any particular topic today. I'm just going to try and do justice to the topic given to me, take you through the many stories of hope and healing and lessons that we have learned over years. So before we start, let me ask the audience here, how many of you have, apart from the hemonc people and the senior specialists, how many of you have seen a child with cancer? The residents? How many of you have seen end-to-end, like not just diagnose and refer, but from beginning to end of treatment and then subsequently follow up? So then I'll probably take you through this journey, what all we go through on a day-to-day basis, what all the families go through, and what makes pediatric oncology sort of different from the other subspecialties. So every 3 minutes, there's a child who's diagnosed with cancer somewhere in the world. So these are some statistics, just for us to know that it's not so rare, but we'll have to pick it up, and all the decisions in oncology are mainly time critical. So what makes pediatric oncology challenging is that children are not miniature adults. This is something we hear day in and out. But what is different in them is mainly the pediatric cancers are all curable. So when we say curable, what do you think, or can anybody guess what is the cure rate of most of the pediatric cancers? Any residents? In terms of percentage? 60? I hear 60. Lesser, higher? Sorry? Yeah, that's honestly the answer. So 80 to 90% of the pediatric cancers are curable. So we have very few cancers which are really associated with poor prognosis, like metastatic neuroblastoma, metastatic osteosarcoma. Apart from that, practically every other cancer is definitely curable. So what is important we know is that it is detected on time and it's referred, and timely treatment and appropriate management is done so that they can have the best chance at cure. So the other problems that we see in pediatric oncology is that it's truly a multidisciplinary management, because we need a multidisciplinary team with intensive care, pediatric oncology support, and then we need blood product support. We need pathologist support because they're going to give us the histopathological diagnosis. We'll need lab services to know what is happening with the biochemistry of the child, and we'll need surgeon support because we'll have solid tumors, orthopedicians because we'll have bone tumors, neurosurgeons because there'll be brain tumors and whatnot. So technically, pediatric oncology in whole brings all the doctors in the hospital together, and also radiation oncology, I forgot. So all of us together are required to treat a child and ensure the outcomes are the best. So this is just common types of cancers where we commonly see. The most common is ALL, or leukemias, which are blood cancers, followed by lymphomas. And when we say solid tumors, so hematolymphoid is one separate branch, and solid tumors is a separate branch. So anything from an organ origin, we call it solid tumor, like the brain, bone, or say from the liver, kidney, while hemat and lymphoid, that will be the lymphomas and leukemias, will come as hematolymphoid malignancies. So we'll see a few common signs. This is just like an introductory slide, and then we'll move on to case-based discussions. So the common signs for leukemia will be the blood lines are affected, so you will have pallor. So the parents note that the child looks really pale, has low energy levels, and you may see some petechiae or ecchymotic spots which they may be presenting with. When it comes to solid tumor, we may see lumps from the organ of origin. Can you think of what are the organs of origins for any solid tumors? Like we can see hepatoblastoma in the liver, we can see Wilms tumor or renal cell carcinoma from the kidney, bone tumors can be Ewing's or osteosarcoma, and similarly you can have tumors which are arising from muscle, which we call sarcomas, rhabdomyosarcomas from the muscle origin. So unexplained weight loss, persistent cough, shortness of breath, sweating at night, these are all just constitutional symptoms as we label them, just indicates that there is some ongoing issue in the body. Abdominal swelling when the organ of origin is from the abdomen. And when you have headache, early morning vomiting, and projectile vomiting, and when you see the Cushing's triad in a patient who's coming with recurrent vomiting, not resolving with antiemetics, then you will think of, is there something that's happening in the brain? So any child with recurrent vomiting, it's good we look at the fundus, we'll have to look into the BP, and that will all give us a clue towards what the diagnosis could be. Limb pain, bony pain, so mainly that goes in favor of bone tumors if we have a swelling, but leukemias also can present with limb pain because there is diffuse infiltration of the marrow, and when the marrow expands with abnormal cells, they're going to present with a lot of body pain. Fatigue, lethargy, dizziness, loss of balance, and eye changes. That is one thing which is very, very important for us, because what is white reflex? Can anybody say? So normally we don't see a white reflex in the eye. When you shine through, you will be able to see only the light reflecting back. So in this, as we can see, this is there is loss of the normal shine. So it is because the mass that is arising from retina, very commonly seen between 6 months and 3 years age group, and can be easily diagnosed by just shining torch into the eye. We'll talk about this later as well, but this is one of the common cancers, and it can be detected in very early stages just by doing the light reflex. But many times it's ignored because the child cannot speak about it because they are really young, and by the time they reach us, they come with really boggy swelling, the eye protruding, and at that point saving life itself becomes difficult. So we'll start with a few cases and we'll quickly go through. So here we have a child presenting with prolonged fever, body pain in a 6-year-old girl, and there's hepatosplenomegaly, pallor, CBC reveals pancytopenia. And what is the next thing that you will look at? If you answer, we can go fast. So anytime you have organomegaly and pancytopenia, we'll have to look whether there is a possibility of leukemia in these kids. So in which case we ask for something called peripheral smear, and we'll be able to make out blasts, which are the abnormal cells or the leukemic cells. So they are originating from the WBCs. So once you know this, we know that we're dealing with a blood cancer or an acute leukemia. Subsequently, we work them up and we start them on particular treatment. So whenever we're suspecting leukemia, there are certain things that have to be done on priority basis, because we know these are abnormal cells and they can lyse. So as the cell lyses, the content of the cell can release into the blood, which can cause haywire changes in the electrolyte balance, which is something called tumor lysis, and that is what we want to prevent. So anytime you see a child with leukemia, we hydrate them, we avoid adding potassium in fluid because already they're going to be hyperkalemic, ensure the urine output is good, and refer to a pediatric oncologist. So the main idea why these things are to be ensured is even 6 hours of hydration will make a huge difference in outcome. Sometimes when they present with hyperluc and we don't hydrate them, the chance of them going into renal failure, requiring dialysis multiple sessions is very much higher. So the next will be a 14-year-old child who presented with respiratory distress, is unable to lie down, so has orthopnea, and we can see that you did an X-ray and this is the picture like. So here we can see there's an evident mediastinal mass, and this child presented to us with bilateral pleural effusion also. It's mainly because of blockade of lymphatics. Sometimes there will be, this is a lymphatic mass or like a lymphoma we call. It can be associated with leukemia as well. So that means the cancer cells have infiltrated both the lymph nodes as well as the bone marrow. When they present with a lot of fluid overload and renal failure, so this child required bilateral, we can see chest tube which is draining the fluid, because that will help us immediately reduce the respiratory distress. And once we start steroids, within 3 days we can see the fluid is cleared. We've been able to remove one side, the pigtail. The other side is still remaining. We were planning to remove it the next day, and the mass is also fairly reducing in size. So the moment we start treatment, that is when we expect response also to come, because these are problems that are arising because of the abnormal cells. So if we want to just manage the critical scenario, assume the child will stabilize and then we will start treatment, it is never going to happen. So finding the fine balance between the two and initiating treatment at the earliest is what is going to be life-saving. And when we have such scenarios, usually it's very time critical decision, because you can see the huge mediastinal mass, they will present with a lot of respiratory distress, and in those cases we cannot be going ahead with a biopsy. We generally prefer to do a pleural tap, and even from the pleural tap we will be able to isolate the cancer cells and do something called flow cytometry, which will yield the diagnosis. So always we go from the least invasive test of all and subsequently higher up as and when if we don't get the diagnosis. And this was another child who presented to us with hyperleukocytosis. So you must have heard of hyperleukocytosis, where the cancer cells are in excess of 1 lakh. So the infiltration is what we can see here. He required HFNC support to come out of the acute illness. And he also had effusion requiring pigtail drainage. And it took almost 7 to 10 days for the child to stabilize out of this. So tumor lysis is something we've already spoken about, and it's time critical, ensuring electrolytes, not adding additional potassium, monitoring urine output and the lab parameters to prevent complications of renal and cardiac and CNS in the form of seizures is very, very important in these scenarios. So we also had a 14-year-old child who presented with abdominal distension. So this is a case of lymphoma, where it starts from the lymph nodes, and the diagnosis is Burkitt's. Usually we see Burkitt's from the abdominal masses. They may present in various forms with abdominal distension. They can present with intussusception, blood in stools, or just neck nodal mass. But what we have to remember is Burkitt's divides like every 24 hours the mass can double in size. So they will come to you with a very, very short history, 1 week, abdominal distension, child is already sick, malnourished, and is already having tumor lysis, because the cells are really fast proliferating. So I'm not sure how clear this picture is, but this was when we inserted Ryle's tube. All we saw was just fecus like aspiration. So he already had gone into bowel necrosis and had a really stormy course. And when he came back, this was how he was, like after 6 months of treatment. So Burkitt's is one where the initial course is very stormy, because it's a very, very fast growing tumor, and the treatment is very intensive, and it is short treatment for 4 to 6 months. But it is one of the most rewarding tumors to treat, because the survival is 100%. Once we phase over the first initial stormy period, the chance of recurrence is very, very less. So this is something that is truly rewarding for us to treat. And this was another child who presented with a posterior fossa mass, was operated outside, and came to us with this kind of a swelling post-operative period. So this is a pseudomeningocele which is formed because of the pressure in the local site, and the aspirate from that revealed around 800 cells. So the child had developed post-op complication in the form of ventriculitis and meningitis, required about 6 weeks of antibiotics to just cure the same. Subsequently underwent radiotherapy and is on chemotherapy now and is doing completely well. So the lesson we learned from this is it's very important for us to have a multidisciplinary team involvement right from the beginning. It's possible that the child was seen only by neurosurgeon, and then they treat the complication. They don't think of ventriculitis, because main reason is that they're not aware of the further steps, that radiation has to be given, chemotherapy has to be given, and all these decisions are time critical. So usually 4 weeks is maximum gap that we keep between surgery to radiation and radiation to chemotherapy. But they went on treating the child with antibiotics for about 8 weeks, when the child neither received chemotherapy nor received radiotherapy. So all these increases the risk of recurrence. So it may not be an acute problem, but it can happen over time. So whenever we see any child with any tumor, involving all the necessary teams upfront, so that they are involved and they give their inputs appropriately, is very, very important. However, thankfully the child is doing well, is in almost fag end of therapy, and this was one thing which is important. Next is we had a 8-year-old girl was diagnosed with TALL. So T or B are just two different types of blood cancers. They can be lymphoid origin or myeloid origin. Within the lymphoid, we categorize them to B, T. There are a lot of subcategories which we don't need to worry about. So what had happened is this child presented with limb pain and fever of long duration to a pediatrician. So the child was already started on steroids because they did not find any evident reason and had received almost 6 weeks of steroids before reaching to us. So what happens whenever they receive this kind of a steroid pre-treatment is what we call, is that one, steroid is an important drug for treatment of ALL. So what happens when you give an important drug as a single agent for such prolonged duration is that it induces resistance. So when we put the child back on steroids for the management of ALL, they become resistant, they are at high risk of relapse, and they may not even go into remission. So all this brings down the prognosis from, say, TALL, it's about 60% to about 20%. So that makes a huge difference when it comes to outcomes of management. So this child had a really stormy course where in induction, mid-induction, she developed headache, vomiting, and we went ahead with MRI. We can see there were some cerebritis features which were there. And usually when they're neutropenic, we don't pick up anything on imaging also, nothing on clinical examination. So on neutropenic period, we will auscultate the chest, looks clear, it will be clear only because there are no neutrophils to fight. Why the child is neutropenic is because of the disease, and we are in the induction phase when the child has not gone into remission. So that means the body's immunity has not gotten back yet. So the child had this brain abscess, and once the count recovered, we had a repeat scan, so we can see these well-formed ring-enhancing lesions. So that means the infection has become formed, and now the neutrophils are come and they're going to fight. So usually the steroid pre-treatment not only puts them at high risk of relapse, but it's also going to increase their risk of infection, because steroid is an immunosuppressive agent. It's going to increase the risk of bacterial and fungal infections. And now more infections means more delay in chemotherapy. More delay in chemotherapy will again affect your outcomes because you can't complete the intensive chemotherapy in the background of such severe infections. So it's a vicious cycle. So ensuring we document the bone marrow before we start steroids for any patient, even if you don't have answer, to get that answer is very, very important. Why limb pain? Why body pain? Why prolonged fever? So ensure a bone marrow aspirate and a biopsy is done. You document there is no leukemia before starting any steroids, especially in these kind of clinical scenarios. And this was a white reflex we were talking about. So this is the child who presented to us. So we saw the white reflex, which was a representative imaging, and that looked very simple to see. It was something just like this, where the tumor starting from the retina is well confined within the retina. So we know it's the innermost layer of the eye. So there is a good amount of size in the vitreous humor where it has to grow beyond. Only then it's going to come out to the anterior chamber and then subsequently outside. So as per literature, it takes about 4 months for a child or the tumor to grow out and come out, and also to metastasize to various parts of the body. So if something like this, if it can be detected, so here we can salvage vision. There's no question of salvaging life or eye because it is 100% guaranteed. When we detect a retinoblastoma at this stage, the child is going to 100% survive. The chemotherapy is very basic, it's very simple, and it's not at all fraught with complications. So detecting at this stage versus detecting at this stage, here we are going to put the child and the family through enucleation, where we have to remove this eye, and that comes with a lot of psychological issues, and even when the child grows up, there is a lot of complication. Apart from that, we are also creating time and channel for the disease to spread to other parts of the body. So it's important that we detect it at this stage. Now, how can we detect at this stage? We're not going to shine light into every child's eye and see. So can you think of any ideas when we can look through all these? So I would sincerely request each of you to just do a simple light reflex during every vaccination visit, because at this stage you can detect even during the vaccination visits. And many of the times when they come for vaccine visits, when they don't have any other complication or symptom, 100% the tumor will be in group A or B stage, which is in this phase, where there is no question of saving life or eye because it will happen. But once they go to a more locally advanced state, it is not possible to save the eye. So that's out of question. You have to remove it. Subsequently, saving vision, that's also out of question. This kind of eye is not going to come back to have a normal vision, and we're going to remove it for all practical purposes. And once it metastasizes, the chance of saving life also becomes questionable. So a simple intervention like just looking into the eye reflex at every vaccine visit can be really life-changing. Now, how common is this? How many will we get? Like, okay, we do it for a month, we don't pick up even one retinoblastoma. Should we stop? There is no way you will pick up one retinoblastoma in a month by shining torch into everybody's eyes. It's not going to happen. It's a very rare disease. But doing this is a commitment, is the simplest step all of us can take as pediatricians in helping save some child's future. We don't know, we may come across one retinoblastoma, or especially asking history within the family. Somewhere, someone, we will be able to definitely make a difference in their lives. So this was another 3-year-old girl who presented with severe mucositis in high-dose methotrexate phase. So we know high-dose methotrexate is one of the drugs which we use in leukemia management, and that causes severe toxicity. So this was literally the stool that she passed one morning, which we got in our group, the sisters panicking, parents panicking. It's like casts of mucosa that was shed. And after which she developed this kind of rash. So the answer was in something, it was just malabsorption related. It was zinc deficiency rash, although we did consider infectious complications or whether it was methotrexate induced skin changes itself. But when we put the child on zinc treatment, it recovered in about a week's time. So general pediatrics and pediatric oncology are probably the most closely integrated specialty, because in every point, all we have to do is be mindful, think of what it can be, and look for answers. Like Kavan sir already said, I wanted to say that here, what your brain does not know, eyes cannot see. So being open in your mind and your eyes and trying to pick up as many small nuances as possible when we see the child is what is really going to make the difference. And this is another child. It was one of an experience for us. It was one of our early BMTs where the child was treated for neuroblastoma. She developed a regimen-related toxicity. We use a drug called triosulfan, like Sagar sir did mention. So it causes effusions. So very rarely, but it can cause effusions, and we saw that in this child. So the moment we gave triosulfan, she developed bilateral pleural effusion, pericardial effusion. She presented with hypotension in the middle of the night because of pericardial tamponade. And here is her when she was very sick. You can see the pericardial drain side, bilateral ICD, and she was on HFNC because of respiratory distress. And this was 3 days later when she stabilized. So I'm not sure if we should thank the technology or not, but phone did help us at that point. And this is her within a month's time, and the counts recovered and she went back home well. So for children, they are really like magic. They give you the time, but we'll have to utilize the time to ensure we intervene appropriately. So having an ICU backup, a multidisciplinary team, somebody who's on the same page to discuss the problems and are truly committed towards getting the child out of the critical situation is utmost importance in pediatric oncology and BMT. So these were some of the soft tissue infections which we dealt with. More commonly, we would see in summer months. This was an axillary infection. This was a perineal infection in an adolescent girl. And this was a chemoport site infection, one of the worst. Like, we had sent back the child home on chemoport, but he came back with this kind of wound. The port had come out on its own. But however, all of them could be salvaged. And most of the times, these are children who have intense phase during chemotherapy, are on very strong regimens, and are extremely immunosuppressed. And we see more infections in adolescents especially. And this was another child who presented with ALL and paraparesis because there was a paravertebral mass. So there was a long-standing bed sore, and that was treated with the help of plastic surgery and surgical oncology team support. And in the management, we also use vincristine and steroids, which also contribute to some myopathy and neuropathy. And all these drugs make it recovery from the paraparesis very difficult. So paraparesis, paravertebral mass, it's very, very common scenario. We may see in neuroblastomas, we may see in Ewing's sarcomas, and also in ALLs. So to ensure physiotherapy is initiated at the earliest and do the interventions to prevent further worsening of bed sore is very important. This was another child who had a steroid pre-exposure as well, who had a necrotizing pneumonia during induction, had pneumothorax requiring pigtail drain, but of course that was not sufficient because he was developing recurrent pneumos, and then finally went on to require an ICD drainage and recovered well. This was one child who also had a steroid pre-exposure, and with anthracycline induced, you can see the definite increase in size of heart here. So developed cardiomyopathy after using anthracycline. So we use donomycin in ALL induction, which is an anthracycline, and that is known to cause acute as well as late cardiotoxicity. So within the 2 doses of donomycin, and she also had other issues, tumor lysis, hyperleukocytosis, steroid pre-exposure. So it was a stormy induction for her where cardiomyopathy cardiomyopathy was one of the major issues, and EF was about 15%, so we had to use a lot of cardiotonics, levosimendan. She also survived, and she's right now in remission and continuing her intensive phase. This another child who presented during induction developed bloating all of a sudden, and when we did the X-ray, usually we think of constipation, which is the simplest diagnosis, because vincristine we saw causes neuropathy, and we would think it's only constipation because of paralytic ileus, but here we could see air under the diaphragm. And when the surgeons went in, I'm not sure how clear this is, it's a small hole, it's a rent in the small bowel. It was a steroid-induced perforation, which we found. This was a child who presented with chest wall mass. It was an Ewing sarcoma. We treated with neoadjuvant chemotherapy, then went on for surgery, radiation, and then adjuvant chemotherapy. So the reason why I put this here is they would present with respiratory distress, mostly adolescents, and you can see a definite decrease in air entry, and you'll have to work them up as early as possible. Every day we waste after diagnosis of cancer, you don't know when it is going to spread. So something that is just locally advanced can become metastatic in no time. So ensuring we fast track each and every investigation, go for the biopsy, tie up with the right people, and get to the diagnosis at the earliest is very, very important. So as a child who presented with sacrococcygeal teratoma, we have some surgeons here. So I'm sure every surgery also has some specificities when it comes to oncology. Here, we also remove the coccyx and ensure R0 resection is possible so that the best possible outcomes are given to the child. So this was a child who was operated for us. And this child, interestingly, she was 10 months when she presented to us, but from the age of 2 months, parents have gone to the pediatrician multiple times with constipation, but never has the child been examined. So locally, there was an evident mass which was slowly increasing over the 10 months when the child had presented to us later on. So if a local examination was done, definitely they would have worked up. Definitely a CT or an MRI would have been planned, and this child could have been picked up much earlier than before. By the time she reached us, she already has lung mets, but anyway, because GCT is one of the prototype for curable pediatric cancers, the child is still doing well 3 years down the line. But these are certain things where if there is a local pathology or if there is a constipation, the child is coming back to you with the same symptoms again and again, and your treatment is not working, just stop and think. Just stop and examine. Take a minute to see what else could be wrong, or to discuss with a friend who will be able to guide you with some better ideas. So that makes a huge difference for them. And this was another child with ALL who again had a stomy course, so he had bowel necrosis because of infection. So we saw the clean bowel loops where it was a steroid-induced perforation. You can see how the infected bowel looks like. So this was also an induction where this was the kind of stool he was passing, just pure blood. And the surgeons had to go in. It was a real challenge because he was just recovering on his counts, and with 50,000 platelets with multiple SDPs on transfusion, they had to still go in because it was utmost required. And this is the kind of perforation we see when it is an infectious perforation. It's not clean. You can see the bowel also looks very edematous, and there was pockets of pus as well where a drain was put, and subsequently child had to go for colostomy because there was a large segment which was resected, which was necrotic, and therefore had to be resected. And he also had multi-organ sepsis, bilateral ICD, pneumonia, and he had lost about 12 kgs during this period of illness. But this is how he was when he went back home. It took about 1.5 months, but it was one of the important lessons for us, like to never give up, because we never can decide which child will make it or not. Our thing is to find out the problem and do what is best possible. And it's totally, probably all the good things come together and it helps the child recover also. So it was a bad GVHD which we had seen after transplant, and with interventions in the form of steroid and IVIG, he improved and is currently doing well. This is a soft tissue tumor. We saw rhabdomyosarcomas arising from the muscle origin. So here this child presented with this kind of a fungating mass in the limb. So upfront, the child was operated 5 times. It's unbelievable that somebody goes in and operates 5 times when it cannot be resected completely. And we did not have even one histopathology specimen to review. And then they are from Bangladesh. Then when they reached us, this is how the child was. It looks actually better, probably a week later, because it was a fungating mass, and then we had to again re-biopsy to get the histopathology, and then started treatment and radiation. So with 2 cycles of chemotherapy, we can see it made a huge difference. So appropriateness of management and involving the people who are required. The moment you see a mass, just take a minute to discuss with the oncologist who is available around, because the approach is not the same all the time. So, and this child is also doing well. And sometimes it's just not growing pain when they come with limb pains again and again. We know if it's at the starting of the day, if it's waking them up from the night in the middle of the sleep, all those things are definite red flags, especially if you see a mass. So do a simple x-ray, even that can help us identify if it is a malignant tumor or what is happening inside. So these were some cases where we could try limb salvage surgery. So limb salvage is definitely possible now. Until probably 15 years back, when prosthesis was a long dream, amputation was considered the only choice of treatment. But now we can start with chemotherapy, shrink the tumor, and then also use prosthesis and ensure their limb is salvaged. Some of the times they get complicated whenever there's an underlying pathological fracture or the tumor is very huge. This was one child whose graft we lost because the skin is really thin and stretched in the tibia, so the chance of graft failure is high. So he had an implant exposure, still went on to come out of it subsequently. So bone tumors, again, do not waste any time. The earlier we diagnose, the faster we can intervene and ensure limb salvage is possible. So when it comes to cancer cure, we truly need a multidisciplinary team. It's not one person. Oncologist alone cannot go anywhere because we need surgeons, we need pathologists, we need radiation oncologists, we need lab technicians, we need pathology, hematology support, blood bank support, and now we are even advancing into stem cell transplant for the refractory and relapsed leukemias. So it's truly a multi-directional therapy. And apart from that, what is also required for coping up, it's very important that we tell the parents. It's not like immediately they will accept. It's something that it's very hard even for us to imagine how can a child have cancer. So we usually take the help of other social support for regular activities for parents to cope, art therapy, educating parents, handing them booklets, infection control, keeping them actively involved in the care of the child, because whenever they're idle, they're only going to sit and think, why did my child get cancer? But when they're more involved in care, they feel more contributing to the improvement of the child, and it keeps them positive as well. Psycho-oncology services, volunteers, social workers, nutritionists, funding support. So all of this put together, that is how we can finally come up with a very successful pediatric oncology model. So this is a happy mother. So of course not happy, like that's when her child was diagnosed with APML and was on treatment. But this was something she really enjoyed doing. So we used to distribute papers for the child to color. She would take one and she would be coloring. So those are simple things which can really help them cope these difficult days. And nursing training is something which it's integrated into part of pediatric oncology, because infection control, ensuring they are well aware of protocols, because from mixing to administering drugs, all of them are challenges and require precision. So nursing training, educational programs are something that we have to be actively involved in as well. And communication is most important, because counseling parents, not giving too much of negativity. Of course, risk of relapse, risk of death, all that is there. But first, in our country, not abandoning treatment is still what takes precedence. Because if we give them too much of negativity, first thing they will do is run, and they will go to another center, and in that time, there is a lot of time and outcomes that is compromised. So ensuring the right amount of information without overwhelming the parents and doing multiple sessions of counseling so that they understand everything in detail is also very important. And especially if you're referring them out, so it's important you tell them there is a problem, this is the person we're referring to, and be in touch with them. So that one-to-one communication really makes a difference, because they feel they're taken care of and not abandoned. So before referring a child, it's very important that communication is established. So these are some happy children in the ward, where they first 1 month they're very cranky and they come crying. From the second month, they're friends with all sisters, they're friends with all doctors, and they're also friends amongst themselves. So this is one child who was on ALL treatment, this is one hepatoblastoma child who went for transplant, and the mothers also becomes friends, the kids also become friends, and they all come, they are like, okay, I also have intrathecal today, and they just come really happy to the ward, they're happy to see the doctors, and that also probably helps us cope, because you develop a bond with the children. It's not a one-time thing. So it's over 6 months, 1 year, and you see them over years, they grow up and they come back. It's a really rewarding field. And these are some of our survivors, and it's truly, some battles are worth fighting, and we are going to fight the battle for them along with them. This was our smallest BMT child. He was 11-month old, who underwent transplant, happily posing here. 6 months down the line, he's doing well. And that's about it. Thank you.
Thank you, madam. Thank you for taking us, all of us, through the journey of these cancer children. through their tough times from the time they are diagnosed to the treatment, the complications, and till the joy that they get at the time of discharge. Thank you for that. I just want to know the cost of the treatment and how the parents can afford, and what are the support funding structures that are available, either government or other organizations.
Yes, sir. So actually, government-wise, there is a lot of support that is available. But the problems are, there is always issues of delay in treatment, numbers, availability of certain investigations. Those are inherent setbacks of any government setup. When it comes to the cost of treatment, it is different for every cancer. Usually a standard risk ALL may cost anywhere between 6 to 8 lakhs if the child has a completely smooth course. But we anticipate at least a couple of admissions during that entire 6 months period, because all the drugs are highly intensive and at least 1 or 2 infectious complications are bound to happen. When it comes to solid tumors, again it is different for all of them. At least 5 lakhs for the chemotherapy is very cost effective, sir. But what will incur cost will be the supportive care, antibiotics, blood products. And mostly we have a lot of NGO and awareness in our country as well who are supporting for pediatric cancer treatment. So they are willing to end-to-end support treatment. They provide, there are some NGOs who provide chemotherapy, some of them who provide chemoports, some of them who provide the lines. So there is a lot of support that is available. From our end, being proactive and keeping them involved is very important. And one other thing, challenge will be, like when we show good work, they are willing to support more. So it's like a cycle. So when we approach them and we show that we are doing all of this, there are many venues. For support for pediatric cancer, definitely there are venues. And even with crowdfunding option which is available, it is not very difficult to raise funds for pediatric cancer because it's a sensitive field. All we need to know is, actually the challenge comes in diagnosing and start of treatment. Arranging funds can be done, sir. We'll be able to do that. The problem is only the patient has to come and they have to stay. If that can be taken care of, nothing else is impossible.
Nothing, I just wanted to comment. We are very fortunate that northern Karnataka, the expenses are far less compared to the Tier 1 cities like Bangalore. For us, a standard risk BALL, we would be finishing the treatment in around 3 lakhs.
Yes.
So it's almost half if you look in that way. And we've got good NGO support also, local NGOs helping us with the chemotherapy, chemoport and the PIC lines. And also we have recently got Leukemia Crusaders MOU. For the last 2 months we've been working, so we get 50,000 for each patient who walks in. And next ICS will give 25. So almost 1 lakh rupees will be available for the patient the moment the patient is diagnosed. But the rest also we are slowly trying to work out, and hopefully with time and with the administrative support we'll be able to treat each and every child who walks in to this hospital free of cost.
While Tanveer is saying that, I just, there was a striking point that we had a conversation on which made a lot of sense when he said, you know, it's a very satisfying field, but many of them look at it like it's comes with a lot of liability, because the amount of effort that goes into treating a child with cancer, not only in terms of pediatric oncology, ICU care, blood bank support, all of them coming together, it's a lot of work for a very small revenue wise. But when you look at what you're giving back to the nation, he should have said that because he said it with a lot of passion. Because it's not somebody who's surviving for 5 years. We're not talking in terms of survivorship for 3 years or 5 years in pediatric oncology. It's like when they're cured for life. So when we talk about cure in ALL 90%, it means the rest of the life is going to be unchanged for the child. So you're technically giving back an entire child's life, future, and whatever they're going to give back to the nation as well. So that makes a lot of sense and gives a lot of importance as to why timely management and appropriate treatment is important. Like he also mentioned, I think the fund is not an issue. Fund can be arranged. Ensuring the patients reach the right treatment center is what the biggest challenge is.
Thank you.
Thank you, sir.
We'll go to the next topic.
Thank you so much, ma'am. It was very nice to see the happy kids at the end of such a difficult battle they fought. Thank you so much. Coming to the next talk, it's my privilege to introduce our next speaker, Dr. Shrikanta JT, an eminent expert in field of pediatric pulmonology and interventional bronchoscopy. Dr. Shrikanta completed his MBBS, DCH and DNB in pediatrics and further pursued a clinical fellowship in pediatric pulmonology and sleep medicine in Singapore. He has also received specialized training in interventional bronchology from Anconi, Italy, reflecting his deep commitment to advancing pediatric respiratory care. Currently, he serves as consultant in interventional pediatric pulmonology and sleep medicine at Aster CME and RV Hospital, Bangalore. His clinical and academic contributions include several important publications in the field of pediatric pulmonology, particularly focusing on bronchoscopic techniques and minimally invasive diagnostic procedures in children. Today, he will be speaking on the fascinating topic Eyes and Tools Inside the Lungs of a Child, Intervention in Pulmonology, which highlights the advanced interventions in diagnosing and managing pediatric lung disease. We welcome you, sir.
Good afternoon, everyone. You know, Sagar would say, when you hear hoofs, right? This is something that I've stolen from him. You hear hoofs, right? You always think about horses. That is what he kept saying. But you also need to think about zebras. So IP in pediatric pulmonology is like zebras, and the pediatric pulmonology itself has been so, how do I put it, so looked at with such a narrow lens. People think asthma is pediatric pulmonology, end of pediatric pulmonology, isn't it? So you treat asthma, you know how to treat asthma, and also understand what allergies, you're done with pediatric pulmonology. But pediatric pulmonology has much more, and it has really grown leaps and bounds from general pulmonology to sleep medicine. Sleep medicine itself is a completely different branch of medicine now, especially pediatric sleep medicine, and then in the interventional pulmonology. So basically, interventional pulmonology, when I started out in India in 2013-14, people would laugh at me. What are you talking? We don't even get cases for doing simple flexible bronchoscopies, and you're talking about major interventions. Then over the last, say, 12-13 years, we have developed one of the most sought after pediatric interventional pulmonology fellowships of India, and we have already had successfully 4 candidates passing out from our center and practicing all over India, which is quite a reasonable number. And we are continuing the same thing in Manipal. Sorry about that glitch. I'm currently in Manipal, not in Aster. So with that, I'll start. So before I start, see, things have happened over a period of significant time. First, pediatric scopes were not available. Even though pediatric scopes were available, the channel was not sufficient enough to pass the instruments that we were supposed to pass. And then that was the instrument related issues, which has more or less gotten better now. Then the perspective related issues. I have always given foreign bodies to ENT surgeons and pediatric surgeons. What else can you offer that it will be helpful for us, was the first question that was asked to me. When I told them flexible bronchoscopically, you can not only retrieve a foreign body, you can retrieve it without having major complications. Post that, when we introduced something called as endobronchial ultrasound to the pediatricians, they said, I look at the CT, I can diagnose tuberculosis. What else will you add to me, isn't it? So the current crop of pediatricians and the current crop of people are not only getting into understanding what pediatric IP is, they're also understanding the need for doing these investigations in a much better way, so that you can not only diagnose a problem but also give them that appropriate therapy. Next slide. So this was a 15-year-old adolescent drunk during a party, vividly remembers accidental foreign body injection in Bangalore, evaluated by his pediatrician, and chest x-ray was done, treated with oral antibiotics for 7 days because it was reasonably okay. Then had this persistent cough, so came to us. So this was our flexible bronchoscopy, which was introduced in 1967. So you can see the working channel is hardly 1.2 millimeter. There is light source and there is this camera, and you had to see it through a eyepiece. So there was absolutely nothing that you could do with a scope. Just see and come out, nothing else. Probably a little bit of lavage. And this is how we would do and still do it. But now we have video bronchoscopes, and these were the rigid sets that are used from, say, 1887 when the Killian introduced it. So, play. So this was the boy. So So you can see there is a nice bronchial cutoff sign. There is a right lower lobe collapse consolidation. And we passed our scope into the airway. You can see a nice foreign body sitting there. That's your carina, this is your left, this is your right. And you can see this was a beetle nut which was stuck in the right mainstem bronchus. So this is called as a cryo probe. So this is a cryo freezes your liquid into gas or gas into the liquid, and it freezes to minus 87 degrees, causing crystallization of your gas, that is carbon dioxide. And what we are able to do is we can take this foreign body out in total rather than taking it in piecemeal. See, just yesterday we had a foreign body peanut in a child. So we went in, we did a flexible bronchoscopy, we held it with a zero tip basket, if somebody knows what a zero tip basket. Because the foreign body is friable, it breaks into pieces. So with this we are able to hold it in total. There is no breakage in pieces. You are just able to touch the foreign body with the cryo probe, able to pull it out quite reasonably comfortably without having to cause any major issues. So this led to not only getting better. So usually by using a cryo probe, the procedure which would have lasted with a rigid scope or a rigid forceps, say probably half an hour, 45 minutes, 1 hour, could just lasted us 15 minutes. Go in, hold the foreign body, come out, again go inside, take a little bit of chunks of pieces, come out. So within say 15 to 20 minutes we were done with this procedure. So this not only leads to reduced morbidity, reduced anesthesia time, but also make sure that you do the procedure in a reasonably safer and faster way. So we also do a lot of airway stenting. So I'm just giving you snippets. I'm not presenting everything that is being done in our center because of lack of time. So tracheal stenosis, especially post-intubation tracheal stenosis, is quite a significant chunk of our population. And post-tracheostomy tracheal stenosis is also quite a significant chunk of our population. So this was a 14-year-old adolescent, road traffic accident, traumatic head injury and significant facial injury, required endotracheal intubation followed by tracheostomy for prolonged ventilation. So here only you can start realizing that after a prolonged ventilation, there is a possibility there is tracheal cartilage necrosis, the tracheal cartilage will undergo stenosis, and without doing a check bronchoscopy, if you decannulate these kids, the possibility of coming back with a very severe stridor is extremely high. So 2 months post decannulation, developed cough, exertional dyspnea and stridor, and this was the scopy. So this is called as Cotton-Meyer stage 3, almost grade 3 obstruction, and this was almost after we completed the procedure. So multiple surgeries on the jaw, multiple surgeries on the neck. So next slide. So this is what we do. Play. So this is rigid bronchoscope that we insert. This is called as a CRA balloon, which is used to dilate the tracheal stenosis. This is almost, we are not able to pass a 3 mm scope into this. So we take electrocautery cuts of the stenotic area, and once we take the electrocautery cuts of the stenotic area, we go in, we balloon dilate this. We balloon dilate this from the inside, and once we do balloon dilatation, a Cotton-Meyer stage 3 becomes probably normal lumen. So once I take a nice Mercedes-Benz cut sign, so I am serially sequentially dilating the area, and once I've dilated it, I also core the area with my rigid barrel. So this balloon that we use ranges from 6 millimeter to 8 millimeter to 10 millimeter to 14 millimeter. And because this is a 14-year-old adolescent, we were able to dilate up to 14 millimeter. And this is a 10 barrel. 10 barrel means the outer diameter will be almost around 13.5 millimeters. So I'm able to pass a 13.5 millimeter barrel quite comfortably into airways. And this is how you see. But the only complication with this is the chances of recurrence is 30%. So we do upfront tell the parents that there is a chance of recurrence. So if they are very far, they have to travel from a very far place, we give them an opportunity to get a stenting done and then go back. So that stenting will not only help the child in scaffolding the area, also make sure the recurrence of stenosis does not happen. So basically this child came back because they wanted to try it out first. So we went ahead, play the front, move front, front, a little bit more. So we did the same procedure, and once we did with the procedure, this time around we inserted a stent. So we use silicone stents for benign tracheal stenosis. So once we insert a stent, the stent sits like this, so nicely sitting here. So stent is nicely sitting there, and we use appropriate size stents. These are made from a particular company. These are silicon, medical grade silicon, and once we insert the stent sits there. If it is in the subglottic area, we take a stitch from the outside. We call it as hitch with a stitch, so that it doesn't migrate down or up, and that has actually helped us in having a reasonable work in terms of stentology in India and Bangalore. And this is 3 months post stenting. So stent is sitting quite nicely, and there is not much of granulation tissue in and around the stent. Next slide. And this is after stent removal. So usually we take around 6 months to 9 months to max a year for the scaffolding to happen. And once the scaffolding happens and the child is otherwise fine, so we remove the stent, and this is the airway, and we are able to get away from complex surgeries. And we do have quite a significant number of children coming to us with post surgical tracheal stenosis because of complications of surgery itself. So stenting has really helped us in a lot of children coming out of major issues. This is endobronchial ultrasound that I spoke to you about. So basically you see a CT and there is mediastinal lymph node. Inadvertently we say this is tuberculosis. Without even looking at the CT, it can be anything and everything, and that too with immunology department that we have. Sarcoidosis is significantly common. Rarer infections are also very common. This 7-year-old school-going child presented with persistent fever for 2 months, treated with broad-spectrum antibiotics initially for 3 weeks and changed to ATT. So this child was initially treated in Singapore, and because child was not getting better, they did more or less every investigation, but they could not hit a bug. So they did a bone marrow showed a non-necrotizing granulomatous lesion. So because it was non-necrotizing granulomatous lesion, they did not have the courage to start AKT. So the child, being an Indian, came back to India and showed to one of the local pediatricians. And as usual, everything is AKT. So started on AKT. Despite 28 days of AKT, continued to have persistent fever spikes. Then this is how our EBUS scope looks. It is a same bronchoscope but has a ultrasound probe in front of it. This is called as linear probe ultrasound. So we go and biopsy the lymph node from the inside. So this has not only helped us in diagnosing tuberculosis, drug-resistant tuberculosis, sarcoidosis, mediastinal sarcoidosis, but other rarer infections in children, and especially malignancies, lymphomas, mediastinal malignancies, which are quite significant. Video. So this was the PET CT of the child. So you can see significant burden of disease, quite a huge significantly lymph node. So differential diagnosis at this time, having no other lesions, was definitely a tuberculosis, but a drug-resistant tuberculosis probably, or a TB with paradoxical response, or it could be a lymphoma, or it could be anything else. So this is how the lymph node looks from the inside. We do the FNAC from the inside, the way you do FNAC from the outside, we do FNAC from the inside. This is your subcarinal lymph node, and once we do the lymph node, so we also take core biopsies so that we have big chunks of tissue if we have to diagnose malignancies also. And now we are doing cryo biopsies of the lymph node so that the chunk of the tissue is left, and it has really helped us in diagnosing mediastinal Hodgkin's lymphomas quite reasonably well. And then there was a pus pointing, and we removed we just touched and we could drain almost around 50 to 100 ml of pus from the side. And that was the reason why child continued to have persistent fever spikes. And once we take out the pus from there, we just go and use a little bit of argon photocoagulation to close the area, right? And once we are done with it, so within 24 to 48 hours, child was afebrile. So the bag of pus which was sitting there was the reason for the child to have persistent fever spikes. But at the same time, child turned out to be a drug-resistant tuberculosis. So in India, we account for almost 5% of pediatric drug-resistant tuberculosis. So until unless we do not have a diagnosis, even the current NTEP says, please do not start AKT without a diagnosis. So this is also something that we do. If you are not able to pass the EBUS scope, which is 6.9 millimeter and currently now 5.9 millimeter into the trachea, we pass it through the esophagus. So 1 year, 8-month-old apparently thought of as a foreign body, and we went inside, we saw significant mediastinal lymph nodes, had a discussion with the radiologist, said no, these lymph nodes are not normal, they are more than 1.5 centimeter for a very acute illness, so we need to have a diagnosis. So we went in, we did a esophageal ultrasound. So this is how esophageal ultrasound looks. It's very close to your heart, and this is how we biopsy the lymph node from the inside. And once we biopsied the lymph node, the child turned out to be a diffuse large B-cell lymphoma in a 1 year, 8-month-old child. Usually these children present with SVC syndromes, and they are pretty late in diagnosis. So this was something that was diagnosed very early. They took another opinion from Anderson's Cancer Center in the US, and they said this is confirmed DLBCL, so go ahead and start the medications. So this is something that we do very often in our center. So in our center currently we don't do any VATS for lung biopsies, and most of our lung biopsies happen with this transbronchial cryo lung biopsies. So the same cryoprobe that I use for retrieving foreign bodies is the same cryoprobe. I pass it through my bronchoscope, go freeze the lung tissue and pull it out. So with this, chances of pneumothorax is less than 5%, and chances of bleeding is also less than 5%. And it's easily controllable. It's very, very safe. Morbidity is just 1 day. Within the next day, without any complication, child goes home. And it's a minimally invasive. Doesn't have to stay for 5 to 7 days in the hospital with a ICD. And most importantly, it saves a lot of time in diagnosing ILDs for her. So 10-year school-going child, dry cough, exertional dyspnea, intermittent wheezing, 4 years, failure to thrive, height and weight less than third centile. Looking at the child, pandistal clubbing, bilateral fine crackles and expiratory wheeze. More or less, you know, this is a chronic process. It doesn't look like a chronic suppurative lung disease, but definitely like an ILD. So lung function test, mixed airway disease with significant reversibility, with the the vital capacity, FVCA, and the total lung capacity being extremely low. Diffuse reticular opacities, multiple small thin wall cysts, regular cysts. When we see so many cysts in the lung, we also start thinking about LCH, primary Langerhans cell histiocytosis. So we did a screening of the skull. There was no punched out lesions. We did screening of the chest and the bony portions, no punched out lesions. And we had a discussion We had a discussion with our radiologist. They were quite confident this was LCH. But because there was a significant clinical and radiological incongruence, we went ahead and we did a biopsy. This is for us to stop the bleeding. This is a Fogarty balloon. We pass the cryoprobe, and once we pass the cryoprobe, we pass it as much deeper as possible, and until we get resistance. We pull it by say inch, then freeze it for 3 to 5 seconds, pull it out, you get a nice chunk. So with a forceps biopsy, you get crushed artifacts. With this, there is no crushed artifacts. We're able to see almost around 100 alveoli samples with interstitium as well as the alveolar pathology, and we're able to diagnose quite a reasonably good. And in our center, we have published multiple papers on cryolung biopsies in pediatric ILDs, and we've shown that the safety and efficacy of this is extremely good, with almost 100% results in diagnosing pediatric ILDs, because you go and hit the area which is more or less diagnostic rather than just going and taking a biopsy from the apical region, which is the easiest for a surgeon. Because if it is, even though it is a diffuse disease, you go and take it from an area which is more significantly involved, getting a diagnosis becomes that much more easier. And this is also something that we do quite often in our center, whole lung lavage. Whole lung lavage means we really put 6 to 25 liters of saline into the lungs on the same day and take it out. So 6 to 25 liters of saline to the endotracheal tube, either by a single endotracheal tube or a double lumen ETT for different pathologies. So different pathologies that we are usually managing in our center is, being in South India, instilling oil and blowing into the nose and blowing into the mouth is the most common practice. So lipoid ingestion is the very common thing. Mineral oil ingestion, because somebody has kept something in their near their sewing machine, the child drinks it as water and then goes as lipoid pneumonia. That's very common in South. The other genetic causes are CSF alpha, CSF2 alpha and 2 beta mutation, LSI, lysinic protein insufficiencies, MAS mutations, which causes primary alveolar proteinosis. So those are some of the conditions. So 2 year, 3 month old presented with persistent hypoxemia and lung shadows post mineral oil injection 2 months back. This child actually was referred to me from Hubli only, from adult pulmonologist, treated in hometown with antibiotics and oral steroids for 6 weeks. Quite significantly tachypnic even after 6 weeks of mineral oil injection. So this was the lung CT when the child came to us. So basically, when child has mineral oil injection, the mineral oil is lipoid in material. So your alveolar macrophages try to digest it. eats it, but it's not able to digest it, so it spits it out with all the constituents that is there in alveolar macrophages. So it leads to a permanent ILD. So until unless you don't clear the lipoid material, it leads to permanent ILD. And we went ahead and we did a whole lung lavage. So this was just a 2-year-old. We can't put it to a double human ETT. Double human ETT, the smallest size we have is 26 French. We use it for our older kids, say 6-year-old, who have primary alveolar proteinosis, where we are able to do whole lung lavages quite easily. But here we did single human ETT, sequential segmental bronchoscopic lavages of each subsegment, and this was the CT post lavage. And we were able to put in almost around 6 liters in the lung in the same setting without having to do an ECMO, and we were able to extract so much amount of lipoid material from the lungs. So like I said, pediatric pulmonology is not asthma, and pediatric pulmonology doesn't end with asthma until unless, again, everybody is saying the same thing. Your mind doesn't know, you are never going to look for anything. And even if you look for something, please understand there is always a way out to make sure you get a diagnosis for it or probably get an intervention for it. With that, I end my talk. Thank you.
Thank you, sir. Thank you for sharing those very informative cases and interesting videos. Thank you. Can you elaborate more on your experience of interstitial lung diseases? One, you said that causes and all.
Yeah. So basically, pediatric ILD is a very wide range of diseases. So we have diseases which present in neonatal age group. Most of them are more or less genetic. Neonatal child's born, term child, starts having significant distress, whiteout lungs, you give surfactant, continues to have significant distress despite you giving surfactant, requiring very high peak pressures. You continue to be on ventilator for a reasonably longer time, then you get a CT done, then you see significant interstitial patterning. So that itself tells you that this is a pediatric ILD. The only concern here is because we being what we are and what we were, being very conservative in what we do, pediatricians have always been very conservative. You do not get a diagnosis, you are never going to treat them. And secondly, there are a few ILDs which can be treated. So you have your primary alveolar proteinosis which can present in the neonatal age group. You just do a whole lung lavage, the child becomes better, you will be able to extubate the child. CSF2 alpha, CSF2 beta mutations, your Mars mutations can present at neonatal age group. There are interstitial surfactant protein deficiencies where you know it is because of interstitial lung disease. You start hydroxychloroquine, you do give them high dose steroids, IV, they do start getting better. So until unless you do not know this is an ILD, neonatal ILD, you are not going to think beyond just doing conventional ventilation, RDS management, right? So for that, biopsies, now that's the reason why cryolung biopsies really help, because it does make a lot of difference. And now currently exon sequencing, you are able to pick up reasonably good number of surfactant protein C, A, ABCA3 reasonably well. And once you have them, you can actually start prognosticating, telling them this is how the treatment is going to be, and then go on. From 2 years onwards, the disease spectrum changes a little, and more than 8 to 12 years, the disease spectrum again changes differently. More than 8 to 12 years, we start looking of more of connective tissue disorders presenting as ILDs. And from 6 to 12 years, again, there is another spectrum. But again, genetic causes become more and more commoner in the first half of the child group, and more than 6 years or more than 12 years, the acquired diseases become that much more common.
If no questions, we'll go to
very lucid talk. I'm a pediatric surgeon, Dr. Akshay. I heard you in pediatric surgery forum as well before.
Oh.
My question is, when are you going to take out that stent after you put it?
Usually we keep it for 1 year.
Yeah.
Because scaffolding happens and scaffolding takes time. We have seen some of our adult colleagues removing it in 3 months because of complications and the stenosis coming back. So that is the reason why we prefer putting a silicone stent. And now we are currently doing customized silicone stents. So customized silicone stents have really become reasonable, and we are able to see, again, not all the tracheas are cylindrical tubes. They don't, all one size fits all doesn't work here. So we are contouring the airways 3D printing the airways depending on the CT and balloons, and then depending on the CT's contouring, we are making sure that the stent is printed in such particular way, and more or less this is all medical grade silicon, so you don't need FDA approval for this because already FDA has approved for this. So we are doing it, our adult colleagues are doing it, so it is definitely going to come to pediatrics.
So what will be the cost of this stent?
So if the 3D printed stents are probably just a few months away, the cost of stent will be 15K. Because it is done in association with Indian Institute of Science, and it will be for no profit, and each and everyone who needs it will get it for 15K.
Any intervention for symptomatic tracheomalacia?
So symptomatic tracheomalacia again depends on how symptomatic child is. So now we have a child in our NICU, tracheoesophageal fistula, operated. At the site of operation has severe tracheomalacia, but only when the child is very significantly excited or crying, the child has retractions. When the child becomes silent, child is absolutely comfortable. So in these kids, tracheomalacia will improve if we have no major symptoms and the child is growing. If child is symptomatic, child is retracting on a daily basis, and because of retraction there is not only reflux but also child is having failure to thrive, then definitely we go and put those silicone stents. There is something also called as biodegradable stents made of polydioxanone material, which we can put it inside the airways. The only problem with that is it's biodegradable and can last from 6 weeks to 3 months, and it is custom made, can be only imported from Czech Republic for a cost of 3 lakh rupees. Every 6 weeks to 3 months we have to put a new stent. That is where our customized stents are going to be a game changer, and definitely we are just around the corner.
Thank you.
Thank you.
Thank you very much, sir, for such an insightful talk. It's my pleasure to introduce our next speaker, Dr. Harish Kumar H. Dr. Harish Kumar is a highly accomplished pediatric intensivist with extensive experience in critical care and pediatric medicine. He holds an MD in pediatrics, is an FIAP and ISCCM fellow, and has also completed PGPN training from Boston. Currently, he serves as a lead consultant and pediatric intensivist at Manipal Hospital, Yelhanka. He has contributed to academic research with publications including work on P-MIS-C case series in a journal of clinical and diagnostic research, along with clinical work in hyper-IgE syndrome, viscotalric syndrome, and chronic granulomatous disease. Today, he will be speaking on the important topic, calories count, highlighting the crucial role of nutrition and appropriate calorie intake in maintaining health and improving outcomes in the children. On to you, sir.
Thank you very much for giving me this opportunity, IAP Dharwad as well as SDM college. So I am a intensivist by profession and by passion dietitian, because there is one saying, if today's doctors do not become dietitians, today's dietitians will become tomorrow's doctors. The requirement on the floor is so much, because no matter what we practice, patient always wants some advice on the diet. I'm sure you are all convinced about it. So about obesity, if you look at the calorie intake and obesity both go parallelly, and since 1970s and till now, the graph is going steep up. So the calorie intake of human beings has increased more than what it was a century back. This is the largest trial study that is done by ICMR, and they have published it in 2024. What they found out is Indians are consuming very high carb. 62% of their calories are coming from carbohydrate. These are their conclusions. Usually 40 to 50 it should be. And the protein intake is very low, and this is driving towards a record high of diabetes and obesity. We are the diabetic capital of the world. And they also found that refined grains are very high in intake, especially white rice and wheat. So this increases the metabolic risk. This is their conclusions, and we have to work on this. This is how they mapped India. Jammu and Kashmir was not into the study, but every other state participated in the study, and they saw that wheat is on the north, west, and east as well as south is predominantly white rice. These are the two grains that lead our country. Luckily, Hubli and this North Karnataka has millets as well as some part of Maharashtra, maybe some Gujarat or so. So this pattern of eating in our country has to change if we have to change our health status throughout the country. Calories, how much do we need? In around 2,500 calories is what it is told. Hard worker, physical worker may need little more. But people like us sitting in AC rooms, sedentary workers, hardly we need 1,500 calories or so. But what are we consuming? Too much. A samosa is 250 calories, and just a simple roti is around 100 calories. One who goes to gym, you go on a treadmill and see how much time you have to run to just melt one samosa, 250 calories. It takes around 1.5 hours. And that is the energy that we have to put to melt that, and it takes just 10 minutes to consume it. High calorie doesn't give us high health. This is what you become with high calorie. In fact, low calories will bring out the muscles. If somebody is aspiring to build their muscles and health, you have to go on a low calorie diet. We all know this. 1 gram of carbohydrate gives 4 calories, 1 gram of protein gives 4, 1 gram of fat gives 9 calories, 1 gram of alcohol gives 7 calories. It's an empty calorie. We get 7 calories from alcohol. So, though carbohydrate and protein gives 4 calories from each gram, it's not the same when it goes in vitro, in vivo. All calories are same eventually, whatever is the source we are getting from for the body. But when we consume 300 grams of fat containing, we eventually get 294 calories. From carbohydrate, 270 calories. From protein, 225 calories only, because the rest of it goes in spending that much of calories for digestion. The digestive system itself spends. So protein is good because you spend a lot to get it into your system. The digestive system spends it. And eating carb has a other side effect. Insulin, you all saw the insulin pump and all that. And insulin pump, I would back that by saying that if you take more insulin than what your body needs, it is going to be very damaging, because insulin is anabolic hormone. It has effect everywhere. The only good thing insulin does is it pushes the glucose into the cells for metabolism. Rest everything is a problem. What is that? It kicks up the inflammation. Liver detoxification is reduced. Blood pressure increases. Cholesterol. Neurotransmitters go haywire. Oxidative stress. Estrogen in men and testosterone in women. So all these imbalances go on. What happens on the arteries? Insulin is an anabolic hormone. Insulin is an atherogenic hormone. It causes atherosclerosis. It accelerates the atherosclerosis by producing hyperglycemia, dyslipidemia, hypertension, damage to the blood vessel wall inside, clotting abnormalities, and inflammation altogether. So insulin resistance, as you eat more insulin producing food, that is carbohydrate predominant food, especially the simple carbs are more damaging. More insulin always in your system will produce more insulin resistance. The only way to get out of insulin resistance is reduce your insulin production. You have to eat diabetic food. What is diabetic food? Which doesn't presses the pancreas to produce more insulin. Your food should be such that it doesn't produce more insulin. So diabetic food is not for diabetic patients. When I ask for a sugarless tea, they say diabetica. That is not the thing. Insulin resistance will lead to endothelial dysfunction, dyslipidemia, vascular inflammation, eventually cardiovascular diseases. So reduce your insulin today so that you don't become a cardiovascular patient tomorrow. Calorie restriction will reduce the free radicals, also reduce the aging, controls the glucose spikes, insulin spikes all together, and eventually it leads to longevity. Low insulin people live longer. This is the book written, The Longevity Diet. I will read for you, I am sure this is not clear for everyone. The only proven way to slow the aging process and maintain peak vitality is through calorie restriction. There is no other fully proved way better than this for longevity, maybe genes. So these are the books, because longevity comes from reduced calorie intake. So that comes with, there are some fasting mimicking diet they have suggested. You eat something, fill your tummy, but still you are, it's similar to fasting. Fasting has shown to reduce the plasma insulin. This is non-fasting state and this is the fasting state. It reduces the plasma insulin much. So if you take a heavy meal, it kicks up the insulin, and if you do fasting, then it brings down the baseline. Your insulin levels have to touch the baseline. If it doesn't touch the baseline, then you are prone to insulin resistance in near future. So make sure your insulin comes down. Benefits of fasting: it slows the aging. It's an anti-aging process. Can help you in beating addictions. It's great way to start a healthy diet. It reduces the insulin sensitivity. Raises the insulin sensitivity, reduces insulin resistance, can normalize the food craving, promotes fat burning, it clears the skin and whitens the eyes, reduces cholesterol level, it regenerates the immune cells. This was a study which was published in 2013 by Debamita Chatterjee from Pune. What they did is they took two groups of mice. One group of mice were always fed, always available food, no matter whether they are hungry or not, food in abundance. And there was another group of mice which was fed only a little bit of portion of food, and whenever they become fully restless, running around everywhere for food, then a little more food was provided. And they saw that all the overfed mice died much earlier than the ones which were least fed. So then they concluded that low intake of food produces longevity. Eat less, live more. You can see all these tribes, even today they eat much lesser. Food is not available to them all the time the way. We have secured food so much that food is around all the time, and it's very difficult for us to resist it. So we are in between the food throughout the day. So that is a problem. So these tribes, even today, they die of maybe poor hygiene, animal conflicts and those kind of things, and not metabolic diseases. Fasting is a good way. Initial 1 to 2 days of fasting will bring you here, and maybe after that, maybe prolonged fasting may start melting your muscles. So during fasting, it is advised, in between fasting, you take a very nutritive food which is high in protein, so that your muscle don't fast. You want to melt the fat in your visceral organs and other ways, but not from muscle itself. One good thing is, even in prolonged fasting, which muscle don't get dissolved is the cardiac muscle. In fact, cardiac muscle gets strengthened. The heart continues to become strong, no matter your skeletal muscles become weaker with prolonged fasting. That is how you see those olden days people used to lose their energy in their limbs. They can't get up with the stick, but their heart was fine. People used to die like that, right? With a normal heart, they used to die with old age. And now what's happening? People are walking around, jumping around, and heart gives way. Somewhere I am able to connect this probably. Fasting small vessels is to prevent microvascular aging. So the microvascular aging is prevented by fasting. This is a concept called Jatragni. This is from Sanskrit, belly fire. And this is from the Ayurvedic concept. I could not find a parallel thing in allopathy, and it's not equal to our epigastric, acidity and all those things. It's not that. So it's a belly fire, digestive fire, which is important. Jatragni is like Jivana Jyoti. It is the central regulator of health according to Ayurveda. Because people say this is healthy, dates are healthy, the dry fruits are healthy, apple is healthy, 1 apple a day keeps the doctor away. I said, no, 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 no. If you eat apple after 3000 calories of consumption in that day, then it's not going to help you. So all the healthy diet should be within the limit of that calorie upper limit that you can spend that day or in that time. So what is Jatragni? It is the, if the fuel, that is food, is too much or too heavy, the fire extinguishes, that Jatragni extinguishes. Your Jatragni should dominate your food and not the otherwise. Jatragni is high in the morning, that's why you are able to eat a little more in the morning. It's recommended you can eat like a king in the morning, but it reduces as the day passes by. That's why it is connected to the sun. The sun rises, the Jatragni rises. Sun sets, the Jatragni is gone. So avoid eating after sunset. Hunger cramps is your savior. One who doesn't feel a proper hunger every day is not healthy. No matter he may be, doing whatever gym and other things. Jatragni reduces the age. So reduce your food and increase your Jatragni in yourself. If the food loads excess than the capacity of the Jatragni, then in Ayurveda they say the toxins build up in you and those toxins damage your health. So there is a balance between food and Jatragni. If your food is heavy, Jatragni becomes weaker. Make sure that doesn't happen. Food is low, it is PEM. If the food is high and Jatragni reduces, then it goes to metabolic syndrome. Fasting after sunset increases a strong Jatragni. That's why that is recommended even from the Bhagavad Gita and all those. Jatragni is not just about digestion. It is also about reproduction. There are a lot of people going for infertility, not finding a cause. This is strongly related to reproduction. Those whose Jatragni is very weak, they go for infertility and all those things. It is also associated with longevity, disease prevention, better digestion and gut health, stronger metabolism, improves the immunity, more energy and vitality. Mental clarity is there when you fast. If you fast today, tomorrow you are very clear. Fasting and good deep sleep will give a very good mental clarity the next day. Muscle power is good, you are detoxified. So lot of people have recommended 8 hours of your eating time and 16 hours of fasting time. And a lot of these food experts have recommended your eating time, meal should be in a restricted. Don't keep on eating throughout the day, 24 hours, even in the middle of the night. Hrithik Roshan is said to eat he has 1 hour of eating time and then 23 hours of not eating time. And so there are a lot of such people. I'm quite influenced in this with Dr. Pradeep Jamnadas, who is an cardiologist in US, and this is from the YouTube. His YouTubes are available. Please, I request you to watch. He is very influential on fasting and its benefits. He says prolonged fasting or 5 to 7 days of continuous fasting on water or fasting mimicking diet will stimulate autophagy. And autophagy is important because when we are every day our metabolism is going on, food is getting processed and processed and processed, we are accumulating a lot of toxins in our body. And that toxins, to get rid of it, you have to give the gap. Intestine has to rest, the metabolism has to rest. Fasting also stimulates something called SIRT3, which is a soluble mitochondrial protein. It has a lot of health benefits. If SIRT decreases, fat oxidation decreases, disease and aging increases. Whereas if it increases, fat oxidation improves, urea cycle improves, all the metabolism improves. So this also acts as tumor suppressor. It has pro-apoptic gene protein, it is called as, and it also stimulates the expression of brown fat. There is another thing, this is almost the last thing, BDNF, brain-derived neurotropic factor. This is a factor which is produced in us. We don't have to consume it from outside. So this factor is very much helpful for our functioning of active brain and active health of our neurons. It serves as a neurotransmitter modulator, plays an important role in neuron survival and growth, participates in neuronal plasticity, which is essential for learning and memory. If you want to continue to have good memory, learning, please improve your BDNF. It is widely expressed in the CNS, gut and other tissues, the gut-brain axis. So there are books, volumes of books written on this BDNF, not just the CNS, only one molecule. It is so big. It decreases in these diseases: autism, Alzheimer's, Parkinson's, depression. Okay? Decreased BDNF leads to neuronal atrophy and neuronal death. What increases BDNF? Obviously fasting, deep sleep, exercise, some antidepressants is supposed to, and a healthy diet. So try to inculcate all this. Dr. Furman, he's a physician, and his diet formula is health equal to nutrition by calories. Calories in the denominator, your nutrition in numerator. You cannot have nutritive food with very high calorie intake throughout the day. Try to reduce your calories, increase the nutrition within that calories. Then you are going to get health. This is the simple formula that he has presented. I think it is apt. Paradox of life is, we as a student used to get a fixed amount of monthly, and we used to avoid going out every day, and it was not possible. So just when your income starts reaching a point where food price don't matter to you, calories start counting. Thank you very much. And humans have been feasting and fasting, so it's not like you should not eat food. Keep feasting, but also be mindful about overeating. Thank you very much.
Thank you, Dr. Harish. Is one of the very few pediatricians, pediatric intensivists who has a passion to talk about calories, because most of the pediatricians or the consultants come, they talk their topic and then they leave. But this is one of the topics that every pediatrician should know, because doctors are the worst patients. You might weigh 100, 110 kilos, you get a child who is obese, and you have all the knowledge in the world to give to the parents, saying that no, the child should get up early, the child should run, should have a good diet, but you are not going to follow that. So that is how it happens. And going by this topic, probably in the last 1 week, if I had seen what calories I have consumed, probably I have to run from Dharwad to Bangalore to burn all my calories. So you have to get the app, get your calories fed into the app. It's not just that having your green tea in the morning, having some good steamed vegetables in the afternoon, and say that I'm going to have 2 butter naans, a chicken butter masala, a chicken something, and then a fried rice at night. So that is not going to work. So you'll have to balance your calories, have a good nutritious food. That is what he said. And we'll have to take that home as a young pediatricians, the postgraduates, everyone, so that our health is the most important. So then only we can take care of the children. So thank you for that enlightening talk on the calories. The calories do count, yes. Thank you.
I have one doubt. How to choose that interval fasting hours, 16 hours, 12 hours, 21 hours? Those things are going on. So how to choose that?
There is one more thing called as OMAD, 1 meal a day.
1 meal a day.
Yeah, so anything about that?
No, Ritik Roshan, what I was telling is all
Ritik or
OMAD
even
only.
Karan Johar also does that.
A lot of people, 1
meal a day. Is it healthy? He also does?
No, not very strictly. Irregularly. Sir, what you said? Gap. We suggest 16 hours. In that 8-10 hours goes in your sleep. Sleep is a best phase where you don't get hungry. Go to sleep in ketosis, empty stomach. When you sleep, your intestine should not be working. They should take rest. If your intestines continue to work, you load your intestine and then go to sleep, then you have given a lot of metabolic load to your body. Your metabolism is on the sky high and then you want to rest. Doesn't work like that. Adapt sleep within that 16 hours. And I said Jatragni is low in the evening, so avoid that evening. Have your meal in the morning, start as early as you want, 8 o'clock, 6 o'clock, whatever it is, and finish off by 1 o'clock or so, and then after that don't eat. Don't eat anything. And this monks, Buddhist monks and other, they don't eat after 12 o'clock. That is their ritual. In those ages, in those days, people have connected all this to the culture and religion and all that, so that people have the willpower to follow that. So let us, if you start 3-4 hours before sunset and then stop eating, next day if you delay by another 3-4 hours, it works. 16 hours is possible. And whenever you are hungry, as soon as you become hungry, don't go and jump on the food. Try to delay. Hunger is your friend. Delay by 1 hour, 2 hours. Have water. Water is 0 calories, highly nutritive. Okay, so those things. My wife, during her pregnancy, also she has had the last meal at 2 o'clock, 3 o'clock. And because I see women giving those examples as I'm pregnant, I'm breastfeeding and all that. No, it's possible. It's possible. So just evening and then early morning with the night, that will make 16 hours also. And it's not hard and fast. People have suggested that. Everybody can have their individual. We know, please go into your body, analyze yourself whether you really need food. I say, if I sleep without food today, am I going to die? No. So only if your body is asking, really hungry for food, give food. Otherwise, don't. So that 16 hours or so can be made. Or you follow 14 hours. And as the younger you are, you can be more relaxed. Up to 30, 40 years of age, you are, to some extent, to a larger extent, health is like given. After 40, 45, you have to really earn it.
Thank you, sir.
Thank you, sir. That was a very interesting talk. Coming to the next talk, it's my privilege to introduce our next speaker, Dr. Chetan Gingeri, sir. He has completed his MBBS from JIPMER and MD in Pediatrics from PGI Chandigarh. He further pursued advanced training as Fellow in Pediatric Intensive Care at King's College, London. He serves as a Director of Pediatrics and Pediatric Super Specialty Services, where he plays a key role in developing and strengthening multidisciplinary pediatric care. Today, he will be speaking on an important topic, building a pediatric team with all super specialties, challenges and solutions. This session will create valuable insight into creating a collaborative pediatric ecosystem and overcoming the practical challenges involved in integrating various subspecialties for comprehensive child care. We welcome you, sir.
So I know all of you are hungry, but hunger is good, as you listened to in the last talk. So usually after Harish's talk, the chefs usually complain to the organizers that this meeting nobody touched sweets and nobody touched rice. So hopefully that also comes true, and Kavan may get that complaint later on. So what I'm going to talk about is basically how the whole landscape of pediatrics is changing, and I'm not going to give too much of gyan. I'm just going to share what the specialty is moving towards. And these are few experiments we have done with our own team over a period of last, I would say, 20 years. And we are kind of at a stage where we are in some ways very lucky amalgamation of people, of ideas, of situations, which has brought together a team of experts like you heard today. And there are also many more who are there back home who are managing the unit. And all this is also corresponds to the contextual times that we are living in. So medical science is evolving very fast. The technology inputs which are there are significantly high. The turnover time about recent evidences which are coming through
is making it very difficult for us to keep updated to most of the scientific knowledge that is coming through. And what it means also is that as a human, as a physician, there is only a significant limitation to what we can remember, evolve our practice into, and practice for the future. And that is where it is very important for us, even though we have our AIs coming in and ChatGPT is helping us, it is also important to understand that there is an explosion of knowledge that is happening at a phenomenal speed, and it is very important for us to collaborate with all the other knowledge experts that are there in our fraternity. So, and also all the juniors and postgraduates who are there with us, especially who are pursuing pediatrics, again, the choice of subspecialty which you need to take in the future will depend upon a lot of factors. One is interest, one is energy, one is your mindset as to whether you are the adrenaline seeking acute care physician or you are an intellectual OPD style physician who needs their beauty sleep. Okay. So all these things are going to make a significant change into what specialties you are going to pursue. We had one range of spectrum, but I'm going to touch upon few other specialties which also already exists. So today the time has come for a super specialty, experiential child care. What do you mean by experiential child care is that parents are not only seeking medical care for children, but also we as physicians need to understand what are their backgrounds, what is their understanding of the disease, and to provide for that the right information, right social, financial and medical support all together. So pediatrics has evolved from what was taken as a very good neighborhood pediatrician focusing on cough, cold, vaccination and an extension of the family. You know, the generations used to follow pediatricians, and from there slight technological advancements happen, especially in the field of neonatology. That is where the acute care started, and then we are now catering to a huge number of specialties. As a team, our main big, hairy, audacious goal is basically to be a children's hospital doing very high risk, high volume, quaternary care, along with a community footprint, because that is what is going to make a significant difference. Like Harish works a lot on pediatric nutrition and obesity prevention. I work on prevention of childhood injuries. There are people working on children's mental health, and these are also the responsibilities of our pediatricians. Beyond a career pediatrician, it is also very important for us to make sure that what are the issues affecting our immediate community, that also we account for and take responsibility to solve for them. A very robust virtual hospital catering to sick children, to telehealth. We had run experiments of managing ICUs in Jharkhand, in Rajasthan and in the Northeast, using our ICU specialists and using the current technology of tele-ICU. And that has really helped and made, because most of these time critical decisions can be taken by trained people. Cutting edge research output and international research collaborations, innovative technology solutions. Some of it you listened to when Dr. Sham spoke about the insulin pump and creating a complete ecosystem for diabetes. We publish a lot, we do a lot of international collaborations. People like Dr. Sagar has got university collaborations with US, with Italy, and within the country itself, with Indian Institute of Science and PGI, we run multiple research projects. Healthcare economic system, making the complex care feasible. When we are working with a team which is doing such complex care of airway interventions, pediatric oncology, pediatric immunology, bone marrow transplants, cost becomes a reality. And that reality we cannot ignore, especially when we are working in a private for-profit hospital. And it's very, very important for us to understand what is the healthcare economics and how can we support them. The question is not what is the cost of the treatment. The right question is that what can patient afford? And then what is the gap and how do we fulfill that gap using all the resources either from the government or from the CSR funding or crowdfunding. There is enough fund in India to really take care of our children. The CSR budget or CSR fund available to Indians is close to 25,000 crores. What is CSR? 2% of the company's profit, and that amount is almost 25,000 crores. If we sell the right story for helping our children, most of the times we are able to source that fund for the treatment of these complex care. So these are almost now, if you take all the medical and surgical subspecialties in pediatrics, there are close to 35 subspecialties in pediatrics. and some of them are organ specific, some of them are not. Some of them up to pediatric neurosurgery, pediatric liver transplant, and those kind of advanced specialties are also available. So 35 subspecialties of pediatrics exist today. And our team operates out of Yelahanka. Some of these I have already alluded to. You have heard those speakers, but there are others and seniors in the team whom I just wanted to highlight. And all this complex care has also got its recognition from both the immediate fraternity, the local population, and also in the rankings. So the specialties are kind of, these are the general specialties we talk about. Children's acute care, which is the pediatrics emergency, PICU, NICU, pediatric surgery. Ambulatory pediatrics, which is a combination of general pediatrics and also community outreach. And child life services, because this is one unique concept we started and experimented with almost 5 years back. We started with a team of child psychologists who were supporting children admitted in hospitals, especially in transplant units, where they were providing all kinds of mental emotional support. Children engaging with play therapy, distraction therapy. So in our emergency rooms now, we are a painless or pain-free emergency, wherein every child will be spoken to by a child life services, and the whole process of cannulating a child is very, very smooth. Within 10-15 minutes, we are able to cannulate extremely agitated children also. Because earlier way was we need 4 people, and then one holds each limb, and there are 2 more people holding the hand, and then we insert the cannula. This is no longer needed with the help of our child life specialist. And then other thing what difference they have made is that our sedation requirements for procedures, especially MRIs, suturing, has significantly come down. We now do even face suturings while the child is completely awake, playing with this child life therapist without requiring sedation. So what it means, child comes, we do the suturing under local, and then we send the child back within 2 hours rather than keeping them till they wake up from sedation. MRIs, we have built a 3D model where we explain to the children that you need to go into the gantry, okay, give them some game to play while they are lying down there motionless, do not move your head, and that also has reduced our sedation requirements for all these children. Pediatric subspecialties you heard about: neurology, immunology, endocrinology, pulmonology, cardiology, oncology, BMTU, and organ transplant. The specialties of future will be immunology and genetics. Dr. Mallikarjun Patil is here. He is joining our team from April, and to set up the Department of Genetics with our team. So pediatric emergency, like Sagar joined our team almost 10 years back as the first DM pediatric immunology. The first DM pediatric emergency medicine has joined our team called Dr. Dilip. So pediatric ICU has come out of ICU, and pediatric emergency has separated itself from the pediatric ICU. Pediatric emergency physicians work not only in the emergency departments of the hospital, but their mandate is to create a very safe ecosystem for transport of children from the site of accidents, from the site of events to the hospital, and also for facilitating good retrieval service for inter-hospital transfers and intra-hospital transfers. So like I told, a lot of child-friendly infrastructure, trained people, and family-centered care, and targeting towards a pain-free care inside our emergency rooms. Intensive care teams, this you have heard. These are all the children who have benefited from fundraising. So every year, almost 5 to 7 crores of funds are raised by our team to help children for multiple things. It can be any other subspecialty, any other complex work that we do. Our motto as a team is that if we have the infrastructure, if we have the skill set, and money is the only limiting factor to take care of these children, we will take that challenge and somehow arrange for the money. Neonatal intensive care has moved on from survival to intact survival. So apart from providing the incubators and things like that, now we have started neuromonitoring them through amplitude integrated EEGs. We are able to diagnose the CNS events much earlier. We are monitoring the CNS maturity of these preterm babies, and also diagnose events like IVH. So for all the specialties which we spoke about, I am not going into that, but we also are building our teams for multi-organ transplants. We are already doing a lot of pediatric bone marrow transplants and liver transplants, but with help of Dr. Srikanta, we are planning to develop a pediatric lung transplant for chronic lung diseases, children with refractory pulmonary arterial hypertensions on long-term medications as well. So heart-lung transplant is something we are looking to work towards. Pediatric surgery, anything from head to toe, and now because of miniaturization of devices, laparoscopic surgery, robotic surgery, and from head to toe of surgery is done by Dr. Dheeraj. Dr. Shanti, you met. Infectious diseases in children have shifted from the tropical infections to more complex infections, because when we are attempting complex work like transplants, the nature of bugs and the resistance pattern of those bugs are completely different. That's why having an infectious disease specialist really, really helps. Dr. Jayalakshmi is the pediatric gastroenterology, and again here miniaturization of devices has allowed us to scope most of the lumen to sort out other liver and biliary diseases and extract so many foreign bodies from the gut. This is the child life services I was speaking about, and you can see here a child getting sutured while she's playing with the child life therapist, and this is the pediatric surgeon who is doing the suturing. These are all children with the child life therapist in the oncology ward. Because they spend close to 3 to 4 months in isolation, it affects their psyche in a very different way, and having somebody to play with them, to interact with them on a daily basis helps really the recovery process to accelerate. Our experiences with fundraising started with this experiment wherein Sagar's pediatric immunodeficiency children were met by class 8 students from Canadian International School. They went back to their school, wrote stories and published it on social media. They then raised funds of around 10 lakhs to provide free IVIG to close to 10 children for an year. And using this experiment, we lobbied with the government, including the parent support group, and today IVIG is freely available in most of the government hospitals for primary immunodeficiencies and also for other acute conditions in the pediatric space, whether it is neonatal sepsis, ITPs, and also GBS. So this was made possible by an early experiment with children helping other children. So I do a lot of work with child safety. So this is the book we have written on accident prevention, injury prevention, and we have raised close to around $1 million US through sale of these books and through multiple workshops that we conduct for prevention of childhood injuries. And our recognitions in the previous institute, because of all this work, both the Clinical Excellence and Service Excellence Awards were given to Dr. Sagar and Dr. Sushma, who heads the Child Life Services in our team. So this is the team that we spoke about. So coming to the topic per se. Now what are the challenges which we face while setting up these kind of multi-specialty services? One is that each specialty has its own challenge. You know, the oncologist need not see 50 OPDs, but the neurologist need to see 50 OPDs. So both are important. So oncologists will see maybe 2 OPDs, but their focus will be on inpatient care, transplant care. But neurologist has to see 50 to 60 OPDs, but then they need support with a different set of infrastructure, whether it is neurophysiology studies, whether it is brain imaging studies. So each specialty will have its own specific challenges. Their work structures are very different. Their space requirements are very different. So when we are convincing management that we require a 4,000 square feet of a child development center as an addition to the pediatric neurology services, they will say that space can bring us more money if given to some other specialty. But then the impact is more when we are dealing with children with behavioral issues, autism, ADHDs, creating a whole ecosystem of helping these children. Again, the outcomes are so good with CDCs. So this has to be educated to all the healthcare administrators also. So space requirements are different, equipment requirement. So specialties like pediatric pulmonology, where Shrikanta practices, is an equipment intensive specialty. You cannot just manage with very basic equipments. It requires certain tools which will enhance their work. It also requires people and their skill levels. So again, very important is that we get the right people with the right skill set, but also the right mindset. There is always a debate about how much we invest into a specialty and what is the output. So the way to handle this again is to diversify your specialty. So there are specialties like pediatric ICU, pediatric oncology, transplant, which make more money. But these are not specialties in isolation. They are all teamwork. Pediatric oncology requires intensive care requires hospitalists and OPD practitioners, and then their work improves because also we have subspecialty cover like pulmonology, neurology, and so that we are not really light even during the non-season days. If you see last 3 years, we have not had any major outbreak. It was only a winter outbreaks of certain viruses. And if you say the seasonal and the yearly dengue outbreaks have shrunk from maybe 6 months to maybe 1 to 2 months, and then again those children are not getting hospitalized. So then our practice patterns also have to change to extend the support to other subspecialties as well. So the solutions are for us to get educated as healthcare leaders and administrators, and have a complete bouquet of services which includes the IPD, OPD, intensive care, share the space with adult physicians, utilize their OTs, cath labs, MRIs, diagnostic services. It is very difficult to build this in a standalone children's hospital unless somebody is really ready to invest so much on a CT scan, 3 Tesla MRI. So those kind of high capex investments can be shared with adult physicians. And early referral system, both internal within the department and external, are plugged into the system so that we are able to help each of our subspecialty physicians practice their craft. So one thing as a working what we do is that none of our subspecialists practice general pediatrics. We have told them don't do general pediatrics. Just focus on your subspecialty. It will take 3 years, but then you will build your department to a level where then you are able to attract patients irrespective of you. Your salary need not be justified by seeing general pediatrics. Leave it to the general pediatricians or the ICU folks, but your subspecialty is your responsibility. Build it up in isolation. Then there are people challenges. It is very difficult to find people who are aligned to this thought. So what is in it for me is the usual thought. But then in today's time, when the focus is so much on work-life balance, it is very important to understand that unless we have a group of people, it is very difficult to find support both in the workspace and outside of workspace when we have to attend to families. So alignment does not mean that you come and follow the leadership, but just to the idea. We also need individuals who are little self-aware and they look at their role both individually for their own progression, but also their role to enhance the larger group as such. Good interpersonal relationship with each other. All of us are colleagues, but all of us are also close friends outside of workspaces. So that really helps to keeping the momentum going. We have to make sure that, despite all the knowledge that we get, there is very little scope for intellectual arrogance, because as I told, science is evolving so fast that in 5 years we can become irrelevant if we are not keeping ourselves up to date. And also because our team is multi-generational, the oldest member of our team is close to 60 years and the youngest member of our team is 30 years. So every generation has its own wisdom and its own quirks and tantrums which are there. So it is very important for us to manage that kind of a multi-generational challenges which are there. The solution, as I told, is basically having more informal conversations. So if many of the subspecialists also may not know, but so for us, for me and Harish, it is like Sundays are very important day of the week. That day we don't see OPDs, but then we sit in the ICU and call, meet each of the intensivists and other NICU people in the unit to just ask what is happening in their life. Okay, some of them may be going through a bad breakup, some of them may be going through a child care problem, but then as a human, if you're identifying your team members' extended family issues and then are able to provide some form of support, whether it is time, whether it is finances, then it really makes sure that they are sticking on to you. The earlier set of consultants, many of them remember that once they joined, all their other outside of work things were taken care of, whether it was maid, school admissions, TV connection, gas connection, things like that. But that has really endeared the team to each other, and we are able to provide that support. We are pushing all of our teammates towards enhancement of personal and academic credentials, whether they want to train while they are being a part of the team, whether they want to go for short fellowships outside. It is very important to keep on top of your academic credentials, but also to your personal credentials. So every 10 years we say that you need to reinvent yourself, not only as a physician but also as a person. So every stage of our life, 20 to 30s, 30s to 40s, 40s to 50s, our aspirations change, our needs change, and it is very important for us to evolve to that and take some help which is professionally available. A lot of these things we have borrowed from the IT industry. They undergo so much of training for so many soft skills, whether it is personal development. So all those things are very important for us also to enhance both our personal and academic credentials. And also there is a general agreement that we solve for all these problems together. So the reach out is much, much faster when the trust factor is much higher. So if somebody is having a problem either with a patient or with a situation, then they don't hesitate. Okay, they don't hesitate to spell it out and also to get together and solve it. What are the perception issues, challenges? Admin has to understand what super specialty needs are there in pediatrics. First, within the fraternity and also and the adult fraternity also, because many times they want to challenge us. No, I will also do this. Why do you need a pediatric subspecialty? I am trained in pediatrics, or I will manage your patients, but why do you need a pediatric subspecialty? But the whole equation is different with children. And again, it is very important to have an exclusive pediatric subspecialty colleague rather than taking adult help. Because I have grown from that phase. Initial days of Narayana, most of our subspecialists were from adult and then helping pediatrics also. But then we find that having our own pediatric subspecialty colleagues really improves the outcomes. And also among patients. Patients also need that awareness creation as to what is available in pediatric science today, so that they come to us on the right time to the right person. Make friends within the system. That is very important. Any hospital we work, whether it is a government, public sector, for-profit, trust hospital, our own hospital or a corporate hospital, always we need friends in the system, and that is some important role that we will have to exercise. Manage the external and internal power dynamics. So there are always political problems. Hospital is like a jungle and there is an unwritten hierarchy. Okay, so the stars of yesterday were cardiac surgeons, the stars of today are oncosurgeons, and I don't know who will be the stars of tomorrow. So when you are working in a big multi-specialty setup, there are always unspoken hierarchy which are there, and we need to manage that power dynamics by leveraging the group. So that means that if all of us stay together, then it's important for us. As individuals, we do not have the power in the system, but as together as a team, we definitely can leverage the power of the group significantly better. And over communication between teammates and with the administration. Financial challenges are primarily, the questions asked are, what is the return on investment when we are hiring a pediatric pulmonologist or an immunologist? So the main idea is that because the disease pattern is changing, it is important to risk diversify and provide that cross coverage and cushion for non-seasonal specialties. And it's also important for us to share that all of us get paid fixed amount. We don't work on an incentive scheme in even while we are in corporates. So our approach is more towards early referral, because there is no incentive for us to hold any patient with us. So we get all fixed salaries, and our contract structure is not through an entity. All of us are individually contracted to the hospital that we work in. That means that every consultant can walk out whenever they want to. So we take care of them so well that they don't want to leave. We have problems in making difficult people leave actually, because the comfort is so much and the support system is so much. So financially, if you're running a corporate hospital or building a team, when you're negotiating, it just means that if you are paying X salary to the team, our responsibility is to make 4 to 5X. And we have always managed to do that, and that is why we have been able to survive for almost now 15 years with that. This we discussed. So this is the leadership team. We have myself and Dr. Harish. We just started long back in Narayana in 2007-8, and then it's just the story of, log judte gaye, karwa banta gaya. So it is a huge privilege and an honor, but also a huge responsibility to manage talents like Sagar, like Shrikanta, like Aarti, like Sham and Shanti. So we are the elders of this group, but then we are ready to hand over the baton to the youngsters who are going to come forward, and they have seen the ethos and they have been part of this journey. So I hope that they continue this journey for the future. For the youngsters in the system, again, I think the days of a solo superstar is almost over, and it is important for all of you to realize that to have a good balanced life, it is very important that you get together as friends, get together as colleagues, so that you can have a good life, you can have a balanced life, and you can really enjoy your career and the happiness that it brings in taking care of children and families. With that, thank you so much once again, IIP Dharwad and SDM to give us this opportunity and to share our journey with all of you. Thank you.
What a fantastic day that we had today. The eminent faculty from the Manipal Hospital Yelahanka group coming here, telling their perspectives on what pediatrics is, what pediatrics was 10 years back, and probably what pediatrics will be in the next coming 10 years, and what all avenues a pediatrician has in his armor or her armor to offer to the child to make sure that the child is safe, healthy, and looking for a bright future ahead. So whatever the pediatrician looks at is to solve the misery of the child, the misery of the parents, have a well-growing child with the peers, less of school absenteeism, and much into sports and a good diet. So this is what we all aspire a child to have and be. So with that, I thank the team from Manipal led by Dr. Chetan, Dr. Sagar, Dr. Shanti, Dr. Aarti, Dr. Shrikanta, Dr. Sham Krishna, and Dr. Harish Kumar for their wonderful insights on the topics that they took today. And thanks to all the postgraduate students who were here. Thanks to the undergraduate students. And we would like to have a small token of love and appreciation to the whole team. So we'll call them one by one. And I request Dr. Achut sir and I think Anil Halgiri sir has left. Achut sir to come on the stage, be with us and give the token of love and appreciation to the whole team. So I request Dr. Shanti M to come on the stage. Now I request Dr. Aarti. Dr. Sham Kiran. Dr. Shrikanta. Dr. Harish. My good friend Dr. Sagar. And the team director, Dr. Chetan, because of whom today's event was possible. Thank you, Dr. Chetan, for all the support, help.
Good afternoon. It's my pleasure to propose vote of thanks for this academic event. My heartfelt thanks to Dr. Niranjan Kumar, Vice Chancellor, SDM University, for his constant support, encouragement, and providing us with such a wonderful infrastructure to conduct CMEs like this. Thank you, sir. I extend our thanks to Dr. Chidanand Shettar, Registrar, SDM University, for his constant support and encouragement. Our heartfelt thanks to Dr. Vijay Kulkarni, Principal, SDM Medical College, Dharwad, for his meticulous planning, execution of such an academic events on and on. Thank you, sir. I thank Dr. Chetan sir and his team, Dr. Shanti, Dr. Aarti, Dr. Shamkiran, Dr. Sagar, Dr. Harish, Dr. Srikant, for sharing their vast experience and knowledge with us and making this event a successful one. I thank the pediatric staff from Civil Hospital Dharwad, SDM Medical College, KIMS Hubli and KLE Hubli, and fellow pediatricians for Hubli Dharwad attending this event. I thank staff of pediatric surgery, hemato-oncology, SDM Medical College for their gracious presence. I thank all the undergraduates, postgraduates of SDM Medical College, KIMS Hubli and Civil Hospital for attending the event. I thank the support staff of Department of Pediatrics and DRH Auditorium, SDM Institute for their constant support in conducting this one. I thank Kiran and team from Manipal Hospital, Yelahanka, for sponsoring the event and taking care of each activities throughout this activity. And I thank today's MOC, Dr. Vaishnavi and Dr. Varsha. I request Dr. Kavan to felicitate them. Thank you one and all. Have a good day. And please do join us for lunch. Yes, yes. Yes, yes. Primary immunodeficiency book by Dr. Sagar. The copies will be available in the Department of Pediatrics. Interested people can approach us. We will give them.
You can talk to Dr. Mahesh and you can collect your copies from Mahesh.